Oh, cool. Okay. Hello, everybody. So we're gonna be starting off with burns, and I kind of chunked it off a little weird, not gonna lie. I have our main management down here, like our very general burns, but I wanted to touch on specifically chemical burns because I know um, it was brought up for you guys. So if you have a chemical burn, like what's the first thing you should do when someone comes in, they're like, I spilled chemicals on myself. Oh no. Running water. When would you not do
No,
running water?
no running, no water because it can activate the chemicals. You just want to brush it off.
If it's dry.
Okay.
Cool beans. That is a good point, though. So, yeah, if it's a dry chemical, because I kind of think of it like Ajax for some reason. I don't know why it works for my head like that. I just know it does. But when I think of Ajax, like it doesn't bubble up or foam or nothing until you put it in the tub and you put water on it and then you start scrubbing it. Then it gets all bubbly. But if you don't put any water on it, it's just the powder still. It'll still be abrasive to the skin. It's still gonna suck, but um, putting water or any kind of liquid onto it will activate that. So yeah, if you have some kind of chemical that was spilled on them that was a fluid, we're going to be rinsing that off and removing any clothing that was spilled on. How long should you be running the water on the person for? That was a really weird way for me to word that question. At least you got it. Thank you. I was like, I don't know if that made sense. Yeah, for at least 15 minutes. Um, I love thinking about the little eye wash stations that they got for like in high school and stuff, and the big old shower thing. I remember like my last day in high school, one of my friends was like, "Can I pull it?" And the teacher said, "Yeah," and like the nastiest looking water came out of it. But it still works. The water came out. So but yeah, and then overall, like at the end of it all, let's be real. I don't know much about chemicals. I'm not a chemist or physicist or whatever scientist deals with that. So you're gonna call somebody else. You're gonna get in contact with the Poison Control Center for advice as well. If I'm gonna be frankly honest, I don't know if this exists in the hospital. I think it does, but there is like a like yellow, I think it was yellow, like book and it had all of the stuff where it said like here's the chemical, here's the reaction, here's what you do about it. Um, but I remember having that at some of the care homes I worked at, but I've never asked about it in a hospital, but it would be nice if they had it there. But yeah, that's pretty much all on your chemical burns. I am terrible at talking and typing, so I am copying and pasting from a copy that I have because I filled this out before because I didn't want to mess it up. I'm not a gamer. Sorry, Diego. God, so mean. But yeah, so remove the clothing. If it's a wet chemical, running water, call poison control. If it's dry, brush it off. And that is just that. Okay. And then now we're going into our more general burns. So, um, you know, what is our main priorities to maintain life? Yeah, I was like, please say ABCs. Yeah. So we have our airway first, right? If I don't have an airway, then the patient's gonna go within a couple minutes. Um, so this one's kind of scary when you deal with this. If you have any burns around the head or like there was smoke inhalation, you can have some really quick swelling. Um, so if you have a burn greater than what percent, you should intubate immediately. Electrolytes is another important thing that we will deal with. 35 to 40, yeah. So intubating early before swelling and having some aggressive therapy to make sure that their airway does not close up because if it closes up, I might have to put a trach in, and that's another whole issue that I don't want to deal with. Um, but yeah, especially, if you haven't gotten to that point yet, that 35 to 40, but you see that there's burns to the head, you see charred nose hairs, you see soot in the mouth. Um, I just realized it says burnt Bose hair. um, then you would also want to intubate. So, knowing this, we have a general idea, but what are some signs that this person's going to have an airway issue? Like you start seeing them have a change in condition. What alerts you to like maybe I should intubate like now?
Wheezing.
Wheezing's one, stridor, stridor. Yeah. I don't know why for some reason every time I see stridor, I think strutter, like from Kiss. I don't know. Breath sounds, rise and fall of chest. Yep. Um, obviously our hypoxia, if I start seeing our SATO2 start going down. Um, let's see here. Da, 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 stridor, breath sounds.
Hoarseness.
Hoarseness, yeah. So if they have a change in their voice, which can be kind of hard, right? Especially if we don't know their baseline. I think stuff like that kind of comes important when you have people around them. That's where I feel like family really comes into play because they'll be the ones to say like they don't normally sound like this or they don't act like this. Something's wrong. So they're the ones that know the patient best. I actually had that instance happen to me a few times where they said like something changed from overnight and it was like on paper it didn't look like it, but they know their family members best, and ultimately there was a change. Barking cough is another one, kind of like when you guys went through 222 and you guys learned about all the croup for the kiddos. That barking, high pitched cough, a wheezing or brassy cough. Um,
I'm drooling.
Drooling is a big one. So when they're drooling, it means they physically cannot swallow. That's going to be like your biggest, oh no, oh shoot moment. So I would probably put a little star or something next to that one right here. All of these are still important, don't get me wrong, but your drooling is definitely like, okay, now they can't swallow. There's so much swelling to the point that they can't even swallow. This is a really quick, like they're going to change up real quick on you. Obviously, if we do have airway issue, you guys already know to monitor their breathing, look at their lung sounds, watch for all of these signs. SATO2, and then possible intubation if we have stuff that's leading to it. Like, if we have that big old body surface that's affected, or if you have burns to the head or burns to the mouth, any edema, super edema, yeah, anything, any swelling in the throat that we can see here, whatever the heck, we're gonna be considering this. If they have a smoke inhalation injury, you're also going to want to get some blood gases and a chest x-ray. That's it for that. Oop, you know what I just realized? I didn't even format this right. No. Oh, oh, cool. I didn't know I could do that. I was trying to like go one by one to move this stuff over, but I clicked something wrong and I pushed the tab and it moved everything for me at once. That was great. Well, I didn't know. I'm sorry. He's laughing at me too. This is mean. I would think that, being Gen Z, I would think that I would be a little more tech savvy, but I am not. Oh, it only did some of it. That's okay. There we go. Now we're on to something. Cool, 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 cool. So our next one, going into breathing. So when you have them inhaling a whole bunch of smoke and stuff, what is your main poisoning that you're looking at? Definitely you're getting ABGs, yeah. The ABGs are
Carbon
gonna be big.
monoxide.
Carbon monoxide poisoning. So this is the silent killer. Why is it called the silent killer?
It's tasteless, odorless.
I hope it wouldn't taste bad. That's something I always thought about when it said tasteless. It's like, it's kind of weird. Yeah, it's definitely scary. There could be symptoms, but the scariest thing about it is that their SpO2, their oxygen will look normal. So they're gonna have an O2 and it'll say like 98%. It looks great. Um, you don't really have to know the reasoning behind it, just kind of knowing that it is enough. Um, but when you're doing a SAT-O2, it basically like it can't, yeah, it's binding to the hemoglobin instead. So it looks like it's fine because it's looking at the binding. Um, but yeah, there are some signs and symptoms other than that that could be present as well. What are some signs and symptoms you could see? Oh, I love the nails. I don't know who put that, but I love it. Queen. Queen.
Headache.
Headache is one.
AMS.
Okay, cool, cool, cool. So I'm also trying to like figure out how to how to do this again. I'm sorry. My formatting's all wonked. I did my best. Yeah, that headache, shortness of breath. It almost looks exactly like somebody who doesn't have enough oxygen. Because essentially that is what's going on. The headache, weakness, dizziness. They can't get enough oxygen up to the brain, shortness of breath. They're trying to increase the amount of oxygen present. That nausea and vomiting as well, confusion, that altered level of consciousness, flushed skin, which I remember we looked this up, Diego, at one point. You remember the flushed skin for carbon monoxide poisoning? You looked that up at one point, right?
I thought they were gonna have cyanosis or pallor.
Yeah. Do you remember why the reason for flushed skin was, Diego? Because I remember, Michelle, we thought the same thing when we were going through the course initially. You know, I was thinking, well, they don't have the oxygen.
Because
Oh, come here. Come here and speak into the
I
mic.
think it has to do with the carbon monoxide binding to the hemoglobin. So in terms of like the coloring, I'm not entirely sure, but
I remember you looked it
I think
up.
it has to do with the fact that it is binded to something. Maybe it keeps its color. I'm not really sure. I'll double check.
He'll check on it for now.
Actually, in my notes, it says absence of cyanosis and pallor, so I guess that the opposite of that would be flushed skin, so that makes sense.
Yeah, patient will be related to vasodilation affected carbon monoxide. Oh, that makes sense. Thanks, Josh. I was like, I remember that being a thing, but I just didn't remember how it got there. Okay,
Wait,
that makes
can
sense.
you repeat that, or can you explain that, Josh, or hello? Okay,
I'm literally gonna copy and paste this down into here. Thanks, Josh.
okay.
But yeah, it seems to be from what he says and from what I remember that vasodilation causes a whole bunch of blood to rush to the skin, kind of like how your girl, you always working. I'm worried about you, but get your bag. We love that for you. Kind of like how with your early sepsis, the skin is warm, flushed, because of the amount of vasodilation present. It's bringing all the blood up to the surface. But yeah, crazy stuff. That increased heart rate, some compensation. I like that he put that as well. Increased heart rate and decreased blood pressure. That is something that could be seen as well. Um, loss of consciousness, lactate increase because we don't have adequate oxygenation to the tissue and what?
So a combination.
Oh,
So yeah, it's a combination of increased blood flow for compensation, and then also when carbon monoxide is binded to the hemoglobin, it keeps the bright red color.
cool. Patho stuff. I don't understand the patho stuff if I'm honest with you. It's well, it can help you to understand stuff, but I feel like I get lost in the sauce if I do it.
That's
Cool beans. So when you're looking at their diagnostic for this, you're looking at the levels in the blood. So what's considered a normal level? And then I have a random tidbit knowledge on that one too that I found out. Yeah, less than 10 is going to be your normal. And then when is it like oh God, oh, just kidding. I just copy pasted it. Well, over 40 severe. My bad. That was a my bad, chief. Um, I did find out when I was doing research on this, when I was in 240, that smokers can actually have a higher quote unquote normal percent. So they could be over 10%, and that's their normal. So just a weird tidbit. You don't have to know that, but something I thought was weird. And I told my dad about it because he's a smoker and he will never stop smoking. But you know how it is. Huh? Oh, I was.
Oh, that makes sense.
Oh, okay, cool. Did you finish the questions? No. Okay, so with all of this in mind, we have some pretty serious things going on. What is your form of treatment for this? What's your first line?
oxygen.
Please give them oxygen. Very high flow, so either your masks or straight up intubation, especially remove them from the insult. If they're still in the house that's on fire, please please take them out of the house that's on fire. Maybe not me, maybe the firefighter, but somebody take them out. Take them out of there. Or you know, the scary thing, there's some houses that don't have carbon monoxide detectors, like my apartment doesn't have one. That's technically not very good. That's not to code, but it's important that everyone has it because, like Michelle mentioned earlier, it's tasteless, it's odorless. Like you have no idea until it's too late half the time. So usually, you know, when people are sleeping, it ends up, you know, they just don't wake up. Scary stuff, man. But yeah, if they're in that house still or wherever is leaking carbon monoxide, get them out. Porfa, please. Now, where did I? Okay, it's the circle one. Circle one. Okay, so moving on to our circulation. What is your biggest complication when it comes to circulation with burns? I'm so sorry, you cut off. What did you say?
Hypovolemic shock.
Yeah, so our hypovolemic shock, and this happens with the more amount that is burned. You have more capillary leakage, you have really bad third spacing, and that will send you into the shock. So let me put this here because I'm bad at typing this. So, you know, obviously if we have this, the more amount of burn that you have, the worse off you're gonna be. Yeah, fluid shifts and fluid loss ultimately. It's kind of like a double whammy. It's a horrible double whammy because, you know, you could be weeping fluid outside, but then just because of the capillary leakage, you can also be leaking fluids inside. Signs and symptoms of infection, they are compromised. Yeah, the more skin that is burned for them, the worse off they're gonna be. And their risk of infection goes sky high. And we'll talk about that one in a little bit. I think I have it down here, so we'll come back around to that one in a moment. With your circulation, and anytime we're dealing with fluid balance, what is your good indicators of fluid balance?
Urine output.
Urine output. So what is the goal for urine output to be?
0.5 milligrams per gram per hour.
Darn straight. That is the bare minimum that I need to see. Yes, Josh. Yes, keep putting the nails. Queen. But yeah, that's the bare minimum. I know, I think it's from 232 urinal lecture. It was mentioned 1 milliliter per kilo per hour, and honestly, that is preferred. But at very, very bare minimum, it should be 0.5 mLs per kilo per hour. And you know, when we talk about circulation, we talk about this hypovolemic shock risk and monitoring our fluid status, you know, to make sure that they don't go into hypovolemic shock, we need to be giving them fluids. So your fluid resuscitation in the first bit of time, the first 24 hours from the onset of injury is the most important. Let's see here. This is kind of like a random one. I hope you guys know that it's in the notes, and it's like, yeah, if you have edema, you should be raising the extremities that are edematous. Just a thought. I feel like you guys know that though. I feel like it's not really need to put down. But yeah, so now we're kind of going into this circulation leading into our shock specifically here. If you have greater than what % burn area, you can have shock. What's that percent? Am I tripping out? I remember saying that earlier, but why is there a different number here now? Am I tripping out? I think I am tripping out. Hold up, sorry. Oh wait, that the deep burns greater. I was like, I remember seeing 35 to 40, and I was like, why did I see 35 to 40? That 35 to 40 is for that intubation. But when it comes to shock, it's going to be anything like Tammy said, anything over 10% you can have shock from fluid loss. I will never forget what summer it was actually. So I forgot some of it. But there was one summer recently when I was in nursing school that I got burned really bad because I am very white. And I had blisters all over my upper back, my face. There was a very big percent of my persons that was burned. Why do you remember that? Okay. Well, Diego said it's summer of 2023, so thank you for that. Oh, you were. Yeah. It was gross. It was weeping. So I was quite literally losing fluid out of these blisters because they were pop. Yeah, it was bad. It was really bad. So very technically, because of, how much of my person was burned, I could technically have too much fluid loss. So I can end up in hypovolemia because of that. So general rule, very general. If it's 2 to 3 inches wide, you treat by the provider, or if it's greater 10% burn area, you need to be considering risk of shock. So when we're treating someone for hypovolemic shock, what is the preferred solution? It is LR. And why is it LR?
I also want to replace like electrolytes. Like there's electrolytes in there.
You could be replacing electrolytes, and it is isotonic, so it's a good solution to keep, fluid in the intravascular space. These are both good things. But in specific, LR is very good because it reduces your risk of acidosis because it does something with bicarb. Wait, turns to bicarb reducing acidosis from, turns to bicarb reducing acidosis from lactic acidosis. I don't know why I read that so wrong in my head. But yeah, that bicarb helps you to reduce any acidosis, and it's especially important because if your patient gets septic, you have more lactic acid, sodium lactate, not lactic acid. Jesus Christ and crackers. Wait, where at? Sorry. Here? Question mark, question mark. Oh, saying like, isn't that why it doesn't cause an issue? Oh, you mean the LR lactated ringer? Yeah, yeah, cool beans. Yeah, just I'm not sure the exact. No, you're good, you're good. I'm not sure on the exact breakdown of it into the body. All I know is that when you have a larger percent of it going down, it turns into bicarb, and that bicarb combats your acidosis. Don't know why it happens, I just know it does. So it's really good when you're doing certain things. So, when you have the patient very acidotic, or in this case, where you're doing a lot of fluid replacement for someone that will end up having a lot of lactic acidosis, it would be good for them to kind of balance it out. Very technically as well, it's not inherently a preferred solution, but you can use albumin, right? We talked about that third spacing from that capillary permeability. So you can use albumin to help kind of try to push that back into the right place and then administer other fluids on top of that. Yep, puts fluid back into your vascular space. Additionally, I don't think you guys need to know this, but just a random thing. Your first 48 hours, you could use vitamin C because it decreases some kind of protein and fluid leakage. It kind of helps with that capillary permeability in its own way. It's not a need to know, but it's a nice to know. I thought it was cool. I put this in here as well just because, when we're considering people with burns and the higher severity of burns, we have to consider as well that maybe this patient can't eat, especially if we have that tube in them, right? If they are on a vent because they had that airway swelling, they can't eat. So I need to make sure that they're getting enough food in. When you have someone with a severe amount of burns, their basal metabolic rate also goes up. One, they're trying to heal themselves, and two, something skin. I think more energy goes into thermoregulation because their skin, which was a huge factor in thermoregulation, is now half gone or 25% gone or however much gone that it is. So for these people, it's really important that you're making sure that they get enough nutrients in, they get enough calories in. So it's going to be high calorie, high protein, high vitamin C for that capillary permeability, and high carb. Basically, everything is high for the most part. Let me put this in here. But yeah, that's why I mentioned this about the vitamin C, because I was like, that kind of leads into this. Now, did you guys go over I know you guys had a lecture today and you have one tomorrow. Did Robbins go over anything that you would have to know for specifically for burns? Like he told you guys about like Parkland formula and that you're gonna need to utilize that, right?
Yes.
Okay, good. I was like, please. Yeah, so you're gonna have to know how to calculate it based off of a person's burn injury. So they might give you Perfect. Yeah. So it's the percent of your burn multiplied by your weight in kilos multiplied by 4 mLs. This is going to be very important. I would have this. Oops. Why did it not? It didn't copy over. Oh, I know why I didn't copy over. Hold on. Sorry. There we go. I liked it highlighted too. There's a lot of highlight in here. I cut out a lot of extra information. So there's a lot of very specific things to know here. Give half in 8 hours and then the rest over the next 16 hours. Yes. I think what got me and a couple other people confused the first time we ran through it is that we tried to put the decimal in and then like as we put the burn as like a decimal, so like 0.52 or whatever. And we ended up with like really low numbers and it was like, oh, this doesn't seem right. Something's wrong here. So it's the percent. So don't make that mistake. It's the percent. If it looks really low, it probably is and something's wrong. Just that. But yeah, so first half is given in the first 8 hours after the injury. No, after the injury. Because I did not understand that one either. And then the other half is given in the next 16 hours. Yes, that was where I got screwed over because I did not know. When we did the calculation problems in class, I didn't understand that it started from the time of injury as opposed to when they came to the hospital. So if it took them 2 hours to get to the hospital, then technically I have to give the first half in 6 hours because with doing that 6 plus 2 equals 8 after the injury. But yeah, that's going to be important to remember as well. So you don't accidentally calculate something wrong because the patient took an hour or two to get to the hospital, So when we're dealing with the Parkland formula, we're giving, our LR, which was our preferred solution. We figured out, how much that we need to give in the first 8 hours and then the next half and the next 16. What is guiding your fluid therapy? Like, what should we be assessing throughout that entire time that we're giving this? Urinary output. And then we already went over that goal, so it's that 0.5 ml per kilo per hour. At bare minimum, please, bare minimum. But with every treatment as well, we have risk of going too far, right? When we think hypothyroidism and we're giving levothyroxine, we can shoot someone too far in the opposite direction and give them hyperthyroidism or signs and symptoms of it. If we have someone with really high blood pressure and I give them a whole bunch of blood pressure meds, I can end up dropping them out too far. So on the same kind of strain as that, I need to consider as well that I could give them too much fluid, they can't handle it, and then now I had fluid overload too. So looking at both ends of the spectrum on that, right? You guys all know this. You guys know it. I know you do. But yeah. So to calculate that percent of burn, you need to know the rule of nines. It's not as bad as what it seems like. I remember being freaked out about it because I watched a Nurse Sarah video about it before I even took the class, and I was like, oh my gosh, that seems like so much stuff. It's really not that bad. I really thought it was though. You know what? I should get a little picture of the guy. Let's see, rule of nine. I realize I don't have a picture. Rule of nines. I feel like it helps for those that are visual peoples. Are the arms and head always 4.5? Yeah, genitals are 1%. I'm sorry, I always think that's funny. Okay, wait, copy image. There we go. Here we go. We're onto something. There we go. But yeah, so the arm in total, the arm in total is 9. So the front of the arm is 4.5, back of the arm is 4.5. This is not a very good picture to actually represent that. Here's a better picture to represent. Hold on. Let me switch this out. Switcheroo. Switcheroo. Aha. There we go. So yeah, and then your torso is divided into an upper and a lower half, and just because of how big someone's torso could be, 9%. And on the upper and the lower. So the front entirety of it is 18. The back entirety of it is also 18. Arms are 9 total, 4.5 in the front, 4.5 in the back. Legs are bigger than arms. At least I hope they are. So 9% in the front, 9% in the back. You have this little area right here is 1%. I'm so sorry, buddy. Poor guy. And then your head right here, 4.5 in front and back. Um, yeah, I'm gonna have it written out for you guys too, so that you guys will have that in writing. Because, you know, some people work really good off of the picture. I am not that person for male or female. So basically, if it's in that pelvic region, it'll be a 1%. I think because Robbins makes that question. I know, I think it's funny. I think it's kind of funny. I'm sorry.
He said
I,
we won't have to really worry about the 1% because sometimes his pictures
yes.
don't look like, not clear. That's what he said.
Yeah, that was actually the next point I was gonna bring up is that because he makes the questions, he should have already told you guys that like one, if you're off by one, they're kind of like meh because you know some people calculate it, some people don't, just based off of what the picture looks like. Um, so you know if you're off, let's say you put 50 and the answer is 51, like you're not gonna get dinged for that. It's gonna be fine. It'll be fine. But it's important to know if you know someone has a burned manhood, you know, it be what it be, I guess. I don't even know. No, girl, no. Oh, oh, it's getting worse. Listen, I think it should vary depending, and Josh said slice.
That's crazy. I know some people might be 2%.
People might be 2%. And on the flip side, some people might be 0.5. No, all jokes, I promise. We kind of went over. I'm gonna move on from that. We kind of talked a bit about our assessment of fluid status. There's a reason it comes up so many times. Urinary output, know your number. Oops. Oops. There we go. Know your number. Know that it should be at least 0.5 ml per kilo per hour. You will hear me in the back of your head. I forgot. I think it was, I'm trying to remember who it was. I think it was last semester that they told me, "Oh, I heard you in my head when I was taking the test." I was like, "Oh, that's probably not a good thing." But it helped them apparently. So, if there's anything you remember from this, it's urinary output 0.5 per kilo per hour. Please. You know, we're getting that chest x-ray. We talked a little bit about that, just to make sure if we're seeing any pulmonary congestion as we're rehydrating them. Um, you know, earlier in the session, I know, Josh, you mentioned electrolytes. So, you know, one of our main electrolytes we need to be looking for is potassium. So when we have imbalance with potassium, we have risk of some cardiac stuff going on. So you need to be making sure that this person is on a tele box, they're on a cardiac monitor, because they could have dysrhythmias from the potassium imbalance. Please always get vital signs. I feel like you can never go wrong with an answer on a test being vital signs. Just click it. CO, perfusion. You know, if how we were talking about earlier that there could be compensation, you might have a faster pulse and a lower blood pressure. Why? Because our blood or our fluid is not in the vascular space anymore. It's third spacing. So you might have a weak and thready pulse to deal with there. You might have like a +1. Possibly. We talked about lung sounds and that risk of overhydration, right? So watching for crackles or some weird sounds, pretty much just crackles though. I mean, when you're considering fluid overload, yes, the crackly dackly, some Rice Krispies in there, you know? And then, you know, we did get rid of, or we didn't get rid of, they got rid of technically, but with however much percent of burn that they had, a lot of their skin is gone, and skin is a very big role in thermoregulation. So knowing that, you know, we have risk of, you know, hypothermia. They can't regulate their temperature well at all because they don't have anything to insulate, essentially. Um, so know that you should be having people with like a with more amount of burn that they're more at risk for hypothermia. So we need to make sure that their room is at the right temperature. So the number that was mentioned in your guys' PowerPoint is 76 degrees Fahrenheit. Don't ask me what that is in Celsius. I cannot calculate that. I don't know. Um, maybe some kind of warming blanket or warm IV fluids, but he specifically mentions no bear huggers because it has like a warm air through it, and that can just cause more like insult to injury essentially. They're already down, don't kick them further into the ground. They do need high protein, yes. Where am I at? I think I put it up here somewhere. Here we go. High protein diet, high vitamin C, cal, and carb. Pretty much everything high when we're dealing with these kind of people for wound healing. And then that vitamin C as well for the decrease in fluid leakage from oh my God, capillary permeability. I'd be scared if there was cardiac permeability. That'd be a new one. Okay. I'm kind of jumping a bit. Here we go. You should be monitoring your labs throughout your treatment of this. So what are some labs or group of labs that you would want to look at? And I'm actually going to try to type it out this time. Let's see how well I do this. Anything, throw something.
CBC with differential.
CBC with a diff, sure.
Specifically the white blood cells and increased neutrophils.
Yes, so we're looking at white blood cells for infection. I'm not very good at typing this. What else will we be looking at with our CBC? Infection is a big one.
Your H&H, if they're going into hypovolemic shock.
Yep. I mean, we can see it said blood loss on the PowerPoint, but it's also like, you know, if we're having really bad hemoconcentration or hemodilution. And then additionally, for some reason, platelets as well. I would assume that has to do with the mass inflammatory response, risk of DIC, etc. CMP as well, like you guys were mentioning up in here, CMP. That potassium as well, because it could be lice. Oh, the platelets make sense too. That could happen. But yeah, so our potassium, which could be lysed, and that can be, is it hypo or hyper for this?
Hyper.
Hyper. Why are you dancing near me? What are you doing? Oh, you finished your questions? Nice. Okay, well, I'm still on burns. Please give me a little bit. I'm so sorry. But yeah, so when you have that kind of injury to it, we have potassium moving out of the cell because the cells are dying, they're bursting. So we can have hyperkalemia. So know specifically that you have to look for potassium, but know specifically that you're looking for hyperkalemia. I did a lot of outside research. It could go either way, but for this class, no, it's hyperkalemia.
It was hyper initially, and then it gets way more complicated.
Oh, it gets complicated, yeah.
There's a change in permeability, and eventually the potassium escapes too. And then you have a loss of potassium and loss of sodium.
God help.
So it gets way more complicated, but you only really need to know it's initially hyper, and then it can become hypo later.
I think just for this class, just know hyper. But if you do end up in like a burn ICU for whatever reasons, your electrolytes will be wonked out, and it could be either or. But just for this class, no hyperkalemia. Let's see. I know I saw ABGs, so we'll get into that one in a moment too. What other electrolyte are you looking at? Sodium. Do I expect that to be high or low with someone with a burn? Burns. I never finished my drink.
Increased.
Stop. Sorry, this one keeps messing with me right now. Stop it. So for that one, it's actually going to be low. So in your first week in the acute phase, it's going to be hyponatremia. Weird water shifts. I'm sorry, I don't understand the patho too well on it. I just know that for this class, I just kind of think about it the opposite. So you have hyperkalemia, and if you remember that the sodium's the opposite of that, you'll remember that hyponatremia is what you'll see for your burns. As well as your CMP, what else should you be looking at? We talked about electrolytes, but what other functions could we be looking at?
Your myoglobulin.
That is another thing. Yes. That's not part of your. Yes, that is another thing that's not part of your CMP, but that is another thing that we will touch on soon. But yeah, looking at your renal function, so your BUN and creatinine, creatinine. I really tried to type that out and I really didn't do too good.
CMP. Oh,
But yeah, so
your liver function test. Did we say that already?
you could do it. I don't think it was specifically mentioned in this class, so it wasn't like a need to know, but technically that is something that you would like to know. But for this class, they didn't really mention it. Let's see, we're
Oh,
looking.
actually, yeah, never mind. It's because in lecture he did Burns, HIV, and liver transplant all in one case. So yeah, and then my notes this says LFC because of liver transplant. So yeah, never mind.
No, it's definitely confusing. I remember thinking the same thing, and like I have to look it back up and look at the PowerPoint and whatnot. But yeah, for liver, that comes more into play with like depending on what specific transplant they had. Obviously, if they have liver transplant, then you're looking at liver labs. I think also what you did the outline on HIV. Liver function's affected by that, right?
For HIV.
Yeah, that felt right.
HIV is CD4 and
I don't know.
liver.
I'm trying to remember because they remember we had like a in-class case study. Okay, I'm asking the wrong. I'm asking this guy. Yeah, it can be when T cells go below 400. I was like, I remember I saw something about liver function being affected by HIV, but because this HIV is Diego's content this week, I haven't even looked at it. So I was like, I don't remember. But yeah, you have a lot of stuff go wrong when your T cells go below 400. That is your big like, oh no. Yeah, when viral count is undetectable, that's when you're chilling. Um, okay, sorry. I'll let him get to that when he gets that. Oh, where'd you go? Okay, I'll let you get to it when you get to it. Okay. Okay. So like I think it was Josh mentioned your ABGs, so that's your airway and breathing issues. We can have, maybe some metabolic acidosis. You can end up with Okay. You can end up with some respiratory acidosis, alkalosis, just depending on what's going on with the patient as well. Michelle mentioned your myoglobin, which is great for looking for rhabdo or muscle destruction. I am not very good at typing that out, so I'm copying and pasting it. Sorry.
Okay. Oh, this is so weird. I don't know. I'll send one more. Oh, uh-huh. Uh-huh.
Tammy?
Uh-huh.
Tammy, is that you? I don't know whose thing it is. I'm so sorry. I don't know if it's Tammy. I'm gonna mute you, Tammy. I love you. Sorry, forgive me. Okay, it was Tammy. It's okay. I forgive you. But yeah, rhabdo be crazy though. It's some weird stuff. A lot of times with your rhabdo, like in younger people, it's like, oh, I worked out so hard. I went to the cycling class or I did this and like my muscles hurt really bad. And then the next morning I woke up and my pee was brown. Oh my God. Okay, so cycling's just dangerous. Wife left her. Oh my God. Wife left her husband on the floor for 3. Oh my God. That's crazy. I I don't know why, but all the cases, well, all the ones that I've heard, like from people, when it deals with rhabdo, deals with cycling, and I'm not entirely sure why. But I think that one's kind of a weird association. But
The cycling classes are intense.
I see like some of the videos and stuff, the
They're
ones where they
crazy.
get to the music and stuff, and it's like disco lights and whatnot. Like that looks fun, but then I
It's
keep hearing
hard.
you've done it.
Yeah, I've done it once, and I'm like, no, I'm not. Never again. No thanks. I'm good. I'm
Said
sick with
we're
yoga.
good. We're good. We ain't doing this anymore. Yeah, well, maybe that's for the better. You could have gotten rhabdo. That's some scary stuff. But yeah, so your myoglobin for muscle destruction, looking at rhabdomyolysis, and keeping yourself out of cycling classes. If you have blood loss, you should also be anticipating need for transfusion. So you need a TNC, also known as a type N cross. Doink, put that in there. We talked a bit about that carboxyhemoglobin, so I'm not gonna harp on it again. Just know that if it's over 10, that it's technically elevated. And then the last test for anyone who is a female that is of childbearing age, please get a pregnancy test. Why?
Make sure the baby's okay.
Make sure the baby's okay. Yeah. Poor babies. I don't know why I say it like that. I'm sorry. But yeah, you know, when you guys went through 222, you guys learned of the amount of changes, the physiological changes that happen with people during pregnancy and fluid, the amount of blood volume that's there increases. So when you have someone who's pregnant and they had burns and we're giving fluids, we need to keep that in mind that they already had more fluids in the blood vessels than, you know, what other people would have had. So taking that into consideration as well for the babies. And then if they're really far along, if they're in third trimester, if it gets to that point, you could technically do an early delivery if it's safer for the baby to be outside. For the babies. Little babies. I don't know. I think it's from Bob's Burgers where like it's Linda and she's like, if you're not real, how come I feel this way, little babies? And it sticks in my head, sorry. Um, but yeah, so pregnancy, aggressive fluid resuscitation. Um, you know, we're already doing pretty aggressive with our normal people with burns, but theirs is going to be even more aggressive because of the amount of blood volume that they have compared to if they were not pregnant. Um, yeah. Next one we'll go into is pain. Now, I know that a lot of times we kind of put pain at the back of everything, right? Like, you know, if we have problem with our ABCs, a lot of times we're looking at that first. But pain can actually cause, yes, pain is serious with burns. Why is pain serious with burns? Definitely nerve endings. I mean, depending on how bad it is.
Is it because it's this type of pain has a physiological aspect to it rather than psychosocial? Like there's actually something happening physiologically.
Oh, it's definitely, yeah, there's definitely some stuff happening. Like, I don't know about you, but that sunburn that I had on me was painful. It hurt so bad. The nerve endings are affected, yeah, and depending on how bad it is, like I think it's what your third degrees that your nerve endings get singed, so they don't feel anything. There's no pain with it. Um, but this can be especially problematic when you have that much stimulus because it can send you into shock. What kind of shock am I talking about? Sorry, which one you kind of cut out?
Neurogenic?
Neurogenic shock. That one is scary, yes. So not only do I have to deal with the aspect of possibly having hypovolemic shock, now I have to deal with the possibility of neurogenic shock if this person is in too much pain. Dang it all. Let's see here. Da, da, da. Oh, I just realized something that I missed from the lab section. I realized that I did not put this in for part of your CMP. Your why, God, why? Why is it not working? My format, no. It was going so well, and now it's not. What? Okay, that works. Assessing your blood glucose for hyperglycemia, because when you have that stress reaction, you can have a rise in blood glucose levels, and then increased cortisol as well. So that wasn't my bad. I forgot to put that up there. I saw it in the pain section, and I was like, wait a minute, that ain't right. Something ain't right here. Um, let's see here. We talked about increased caloric needs. Where is it? Oh, here it is. Okay. I was like, I know I'm missing something here. There we go. I was on the wrong part of my notes. Forgive me. So what is your management with pain? I mean, it's pretty straight up. Drugs. Yeah, so we're giving, yeah, careful use of opiates. You can use, you know, that is your first line technically. But you can also use non-opiate option, opiate, something like that. I'm really bad with speaking on this, apparently. Where am I at? Here I am. Okay, there we go. So why do we use these carefully? What is the risk that comes with it? Okay, so that's our decreased blood pressure and breathing issues because this is a CNS depressant. So everything will go down. Your heart rate goes down, your respiratory rate goes down, blood pressure goes down, and they're already pretty much, they could be pretty much bottomed out depending on how bad their burn was. A constipation, I feel like would kill them. It would kill me after like 3 days. I don't know about you, but I have to have like a daily one, right? Like I don't get the people that do every other day and that's normal for them. I'm like, nope, not for me. But the thing that's going to kill them first is the CNS depression with the decreased blood pressure and respiratory depression because they're already having major issues with both or very high risk of major issues with both. So, you know, our opiates are an option, and then we have non-opiate analgesics and other, you know, forms of medication. So you can give neuropathic medications, right? So we were talking earlier about how nerve endings could be affected and damaged. Sorry. I'm so sorry I cut you off. What did you say?
Oh, gabapentin.
Gabapentin, also known as Neurontin, and then Tegretol, cool beans, yes. And then I feel like this one would be pretty straight up, but just to make sure that we have this as cookie cut clear as possible, please give them IV. It's going to be the most direct one if you're giving them, you know, as a as an oral a PO medication. It'll still be absorbed, but it won't be absorbed as quickly or as much. IV is pretty much your direct one. And then we have to have some consideration when we're doing medications IV, right? We need to make sure that we're trying to find a site to even place the IV. That's not burn, singe, or mess up. Like, worst comes to worst, you could really technically do an IO intraosseous, like an in-bone one. You see that in emergency when they can't get one in. Um, you can also use the foot. Yeah, you can use some weird places on people. I remember I saw in the ICU, it was someone that went through somebody's like armpit area, and it wasn't a central line or nothing. It was just a PIV, and I thought it was really weird. But you know, where it's kind of like wherever you can get one in, that's moderately okay. Then you get it in wherever you can.
We also want to use like tactile stimulation.
That is another great one, and that is a great one for your non non-pharmacological, no drug one. So tactile stimulation. So what is that?
Does it have to do with like just how the nerve endings, the nerves get affected by the burn, so you can lose sensation, which will lead to increased sensitivity later on. So you want to provide, like, you want to make sure that they're still stimulating those. I don't know.
I mean, pretty much essentially is that you're dealing with the idea that if you don't touch an area, it could be very overly sensitive. So like I really don't like when people like touch the inner part of my arm, like where the elbow creases, like exactly where you need to go to like draw blood. I hate it. So like before I get a blood draw, I keep like touching my arm there, so it becomes desensitized almost. Side note, most patients typically get more pain as it heals and nerve endings get repaired. That makes sense. Yeah, because I mean, depending on the severity of it, how messed up those nerve endings were, as things start to get rebuilt, as they start to recover, and they gain more sensation, it's not going to be a good type of sensation in some cases. They're going to be in pain. So that's when your opiates come back in, right? Poor guys, I'd feel terrible. My first clinical instructor was a burn ICU nurse, and it was a 1-to-1. And some of the stuff that she was telling me, I was like, dang, that's some messed up stuff. Your final one that you can use is NSAIDs, right? We have a lot of inflammation going on, so you could give some kind of NSAIDs. But what are your risks with NSAIDs?
The BMI and creatinine will increase.
Darn right.
Renal insufficiency.
Exactly, and I like Ryan saying kidney stuff. That's my kind of stuff right there. Kidney stuff. Renal issues, so checking your BUN creatinine, urinary output 0.5 ml per kilo per hour. Example is Toradol IV push. That is something that you could see. Where are we at? Infection, psych, and then general education. Okay, cool. which one I'm at? Infection. Infection. There we go. I was like, where am I at? Okay, so we mentioned earlier really. Oh, I've treated some burn patients. Poor guy. Oh, I've not dealt with a single burn patient, but I've heard stories about it, and I could just imagine how bad it would be. It's some stuff, and from the stories I heard from that first clinical instructor, like it's some really messed up stuff. Um, but yeah, with your patients that have a lot of surface area burned, a lot of their skin's gone. Their skin is acting as a barrier against outside microbes and germy stuff. Oh my god. Oh my god. 55%. Oh my god. That is horrible. Were they were they intubated? Were they conscious? I almost kind of hope not.
No, he was conscious. It happened like a month ago. He'd been there for a long time. It was really sad though. It was a house fire explosion. Yeah.
Oh my god. How was his pain? Like, was he on opiates or?
He wasn't on any opiates. He had no complaints of pain. But he's just been getting kind of agitated because he's going through this stage where like it's like his all the burns are really itchy.
Ooh, it's that healing phase.
Healing
Yeah.
phase.
Super itchy. Oh, I would be irritated too. That's fair. But dang,
So
that
what did you give for that patient? Just like anti-itch creams? Is that okay to give them? Or-
Yeah, that and like some like, anti-infective like prophylaxis creams and stuff like that. But for his dressings, they do this Eugatol treatment and then they wrap it. They only do it every 48 hours. It was really sad. Apparently it was intentional too.
what?
I know.
Intentional, like he's suicidal?
Like someone set the house on fire.
Oh,
Oh my
okay.
god, girl. You've
That's
been
something
getting some
on the
interesting patients recently.
I really have.
Yeah. People are definitely crazy. I saw something in the news like a couple weeks ago, I think, or a week or so ago, about someone like setting somebody else's house on fire. It was like an ex-boyfriend or something. I don't remember exactly, but I was like, dang, like it's never that serious. Come on. Think about the cats in the house. Think about the house. Houses are expensive. Don't do that. But yeah, I think that's something important you mentioned and that kind of deals with our infection right here is, giving, not only the creams for itching, but you're mentioning prophylactic cream as well, prophylactic for your infection. Where am I at? Here I am. I don't know why it's not here on this part of the notes. Why is this messed up? Oh, here it is. Okay, cool beans. Sorry, my notes are chonked up in a weird way, so I'm trying to like go back and forth. But
I was looking to just like look through his medications and stuff on my S bar. I did give him a pregabalin, which is it's like for nerve pain. He had no complaints of nerve pain, but yeah, he gets that twice a day, so that's probably, I'm sure, helping.
oh yeah, definitely like kind of like that around the clock thing where you
Like
kind of
staying,
get to it before.
yeah, like staying ahead of the pain kind of thing.
Yeah. Yeah, probably because getting it twice a day. Yeah. Man's is getting some good stuff. But yeah, we do have that big risk of infection, so we have to maintain very good asepsis. So making sure you're washing your hands, sucios, wash your hands. Having sterile gloves and sterile dressing changes. One important thing when you're doing your wound care for these types of patients, making sure that if you're moving between body area parts, then you need to be changing your gloves. You need to be changing your gloves if you're moving from a leg to an arm. There could be different bacteria, different places. If you're near a groin, if you're near a face, wherever you're at, it could have different like little flora that's in there, and you can accidentally move that to another place that's not as good with that bacteria. Or if they already had infection in one area, you move that infection somewhere else. So we just made things worse. Um, so making sure you're changing your gloves during your dressing changes as well before you move somewhere else, making sure that they have the private room. If you think that someone has an infection, you should probably do some cultures. Could also be different treatments depending on what you're doing. Yeah. I feel like this person, because they mentioned no plants or flowers, I almost feel like it's Oh no, Ashley got kicked out. I see her in the waiting room. She was just here, I swear. Um, it's kind of like for the people that are going through chemo and immunocompromised, there are no plants or flowers in the room. And then if they are on, if they do have a ventilator, if they're intubated, you know, making sure that you're doing what I mean is some areas could be worse than this. So treatment. Oh, I get you. Yeah, so, you know, depending on the severity of burn or what's going on, how it's healing per place, yeah, you could definitely be doing different forms of treatment per site, some more, some less, different medications, etc. That definitely is a big part of that too to consider. And it's important to look at your orders because, you know, it'll say what you need to do for each area. You might not be using the same thing for the entire body. But yeah, if this person is intubated, making sure that you're following your VAT bundle, so mouth care, your PPI, H2, head of bed up, that whole bit. And then if they have the, excuse me, if they have any kind of central line or if they have um, a Foley catheter, making sure you're taking good care of these invasive lines and taking them out if they don't need them anymore. The last one, don't ask me or for a reason. I just know it is. I'm so sorry. I try to look it up. I still don't understand it. They need a tetanus shot. I never figured it out. I'm so sorry.
I'm confused about this one too.
It
It's
was
on
like
the slide. It's also in the little pocket Iggy. I'm like, why?
yeah, to me it seemed really random, but it was like it was so
It's just
far out there that I was like, oh, okay, like it'll stay in my head now because I have no idea why it exists here. But yeah, let's see here. Da, da, da. So that's done. Trying to go through and make sure I didn't miss anything. I've been jumping around a little bit in my notes. My notes are all messed up to the side. I mean, considering considering Ryan's patient, there's got to be a big psych aspect to that, right? Like he's got 55% burns. Somebody intentionally set this dude's house on fire. Like there's got to be a lot of psych stuff going on. Not just like oh, like I'm worried about how I look, but probably like what's going to happen to me after too. Like different kinds of grief per their situation.
I'll be going through stages of grief.
Oh, they'd be going through some stuff. Yeah. So don't ever say, don't worry. It's kind of like if you walked up to me and you're like, oh my God, I just went through the worst breakup of my life and now I don't have a home and I'm out on the street. And I'm like, oh, don't worry, it'll work itself out. It's kind of like, oh, well, okay, well, I'll just go sit in a corner then. You know, it's very, it's almost like rude in a way because we don't know what exactly they're going through. So don't ever say, don't worry. Oh. Tetanus is indicated depending on severity of burn and if soil got in.
Spoiled.
Oh. I mean, definitely depends what was burning too and what got flung up in the air, what got in. This makes sense. But yeah, I've never considered that before, but that does make sense. Now the tetanus shot starts to make sense in my head. So that's good. But yeah, so for your psych, don't ever be dismissive. Don't say don't worry or you're gonna be fine, don't worry. No. You wouldn't say that to your friends. Well, you might because you might not know what else to say, but if someone just told you like they're going through the worst stage of your life, you don't say don't worry, like it'll work out. Like it's it kind of don't work out sometimes. You know, that guy has a lot of burn percent. He has 55% of his person's burn. So we're dealing with some body image issues. I mean, he's been there for a month and he's still going through treatments and he's still getting wound care. So these are pretty bad wounds. They can have a lot of scarring. So at that point we have to ask ourselves, how well are they coping with that? Are they able to look at it? Are they accepting of their situation and what it is? Why are you laughing on the floor?
Or if they're interested in like reconstructive surgery.
Yeah, that could be something as well. Maybe some kind of cosmetic surgery after the fact. You know, once we get this all figured out, you know, there could be things that we could do for you to help with your body image. But at this time, like if you could see if they're accepting, if they're able to kind of like touch or look at the affected areas, if they're doing stuff for themselves, or if they kind of just don't even want to deal with it. That'll tell you a lot about how they're coping with it. Let's see. I am terrible at typing. Why is this not working? I don't know why sometimes the format gets all wonked out. One of these days I'll get better at that. And then we talked about the grieving stages, right? So, I mean, grieving is going to be normal. I mean, depending on what happened, like that guy just lost his house. Like, you might be grieving the loss of your house. You might be grieving the loss of what life you had beforehand. Maybe there's a lot of ADLs that are affected at the end of this all. And he's going to be grieving what he had before. So, definitely going to be normal. And then you have a risk of suicide, especially those that are dealing with a lot of chronic pain, because it's kind of like, why, if I have to go through this every day, what's the point? I'm in so much pain. I don't want to do this anymore. So, watching out for those that have a lot of pain and a high amount of pain, watching out for any indicators of suicidal ideation, risk of suicide, etc. Let's see. General education. I love this section because I love the first thing that's here. What should you never put on burns? And there's a
Butter.
couple things. But yes, butter. Why would you put butter?
I don't know. Like he says that in the audio. I was like, why would you do that?
But you know what? My first job that I worked out, I was working at Carl's Jr. And I remember somebody got burned in the back, and the first thing that they wanted to do was put like butter or mayo on it. And I was like, wait, like in my head, I was like, that doesn't make any sense. But for some reason, people think that. Yeah. I'm like, dude, they're already burnt. They're already crispy. Like, they're not a roast turkey. Yeah, I was like, it's probably old school thing. Like, my mom still believes in people with really high fever, like kids with really high fever, kind of dunking them in a cold bath. She still believes that. And I'm like, that's not recommended anymore. But yeah, no, please don't put butter on somebody. They're not a roast turkey. Don't put butter on them. And also, don't put any ice on them. Their skin's already damaged. I don't want to damage it worse. We talked about the carbon monoxide detectors, and then also, your smoke alarms too. So the second that carbon monoxide is present or this detects smoke or anything, it'll start beeping off. Sometimes it sucks because you'll be cooking stuff and it just keeps going off, but it is what it is, and it's better to be safe than sorry. So smoke alarms. We're teaching hand washing, dressing change, signs and symptoms of infection of the site. Don't stop taking antibiotics. Exactly. Yeah, so making
The water temperature should be at least 120 degrees Fahrenheit.
should be at most 120.
Yeah. I mean,
Okay.
yeah, at most. Yeah.
I was like, wait, please.
Yeah.
Oh, you're good. At my apartment, because of how much one water heater deals with, how many apartment units it deals with, they kind of crank it up. It's not supposed to be that way. But they crank it up to like 140 something. So sometimes you'll be in the shower and it's like burning hot. You got to be careful with that. So that's an example of what not to do. Is
You
exactly.
could sue your landlord.
Yeah.
Get
But
a
honestly, it's like in this economy, nah. I'll stick with what I'm dealing with. I just gotta be careful, making sure that you have some kind of escape plan present for you or your family, your cats, your dogs, making sure you know how to get everyone out in the instance that there is some kind of emergency, having stuff planned, having stuff that you could take with you really quickly, inspecting and cleaning a chimney yearly. If you have a chimney, if you're that rich and you have a chimney, make sure you clean it. There could be a lot of gunk up there. Fire extinguishers in the house, and also really random in the car. Oh, also, yes, sorry, drink lots of fluids and have a lot of protein. So making sure that your diet is good too. Let me put that in there. Dietary needs. There we go. And we talked about that up above. Fire extinguisher, not only just for your house, but for your car too. Please, if you don't have one, please get a fire extinguisher for your car. It's a very good thing to have. You never know when something can happen. If you get hit and you start leaking gas, we have them everywhere. The fire extinguishers for the car? What you mean? Like you have a lot of them or? Oh, awesome. You know, is it supposed to come factory? Because high key, neither of my cars have one. Queen. I forgot about that. We did talk about that. Yeah, no. It's a good thing to have because I mean, you never know. Honestly, yeah, because when I first got my car, neither of them had a fire extinguisher, and I've luckily never had to use it, but I've had to use one for the kitchen before, and they're all different types. So do your research, look into fire extinguishers for your home and for your car because you never know when you're going to need it. Better safe than sorry. We talked about the dietary needs: high cal, high carb, high protein, high vitamin C, the high everything. The water temp less than 120 degrees. That probably helps if I put less. Don't smoke in the bed. I don't know why you do that in the first place, but probably not a good idea. Making sure that they're keeping the wound clean, dressing changes, and your signs and symptoms of infection. And then we kind of talked about this one already. For your infection, if it's open, there's a risk of infection. You have that risk of auto contamination, which is why we were talking about changing the gloves between different parts of the body. So wound on the leg versus wound on abdomen versus wound on groin versus face versus this versus that. Um, and then making sure that you're putting some kind of prophylactic antibiotic on top of that. So you could put something like maybe like a gentamicin on top, but with that one, that is part of the aminoglycoside class, and that one has a risk of renal function impairment. So watching that as well. A lot of your antibiotics do, so just making sure. Hypovolemic shock, we talked about that. Oops, we talked about that up above. So just making sure that you know all the stuff that you need to be doing, how to calculate your Parkland formula, and knowing that the higher percentage of burn that you have, the more fluid loss you have as well. Gastric ulcers, these people are under a whole bunch of stress. So making sure that you're doing your H2 or PPIs to prevent any stress ulcers, and making sure that if they are on a ventilator, that's part of your VAT bundle as well. Respiratory, watching for signs and symptoms of distress. Your drooling is a very big one. I repeat, your drooling is a very big one. Drooling, can't swallow, your dysphagia, that means impending obstruction. It's happening. If they went from stridor or they went from wheezing to nothing, that's even worse. So at that point, we had a sound and now we ain't got no sound. So that part of the airway is already gone. So that's an impending airway obstruction. Intubate immediately before you have more swelling and more stuff going on. With your tissue hypoxia, I know we didn't talk much about it. It wasn't really heavily mentioned in when triaging. They are the priority when you triage. Definitely so, you know. You guys just had that lecture today for emergency and DKA, I think. My weeks are getting all confused. I don't know anymore. But yeah, so you know, when we have someone that's like they can't swallow, they're drooling, they look like they're in respiratory distress, yeah, those are going to be your priority right away. Tissue hypoxia, it wasn't really mentioned heavily in his PowerPoints, so it's a very, very small section on here. But just knowing that if you do have a burn that goes around the body part, aka goes around the circumference, hence circumferential burn, you have a risk of compartment syndrome, and the fix for that is a fasciotomy. You can also do escharotomies if you have a lot of eschar on top of the wounds to make sure that things are getting down, antibiotics are getting down where they need to go, and there's no risk of bacteria growth from that. Pain we talked about as well. It's just going to be copy and paste from the section above as well. And I think that what time is it? Oh, I took up a lot of time. I've been talking a lot. I need to make sure I have enough time for Diego to go through his stuff too. Ooh. I know we talked about a lot of stuff. Burns is probably the heaviest part of this week. As you can see, your organ transplant does not have very much. Ooh, a toaster. Your organ transplant literally just got these things that were pretty much the most important things that you were going to need to know. And then HIV is a little bit more, but your burns is definitely the heaviest thing. Is there any questions on that before we move on to the organ transplants? Oh yeah, definitely. You're given a lot of meds to help with the transplants. Yeah. So those are the main things that they want you to focus on is your patient teaching before and after the transplant, what they need to be doing, what they need to not be doing, and then your types of rejections, what do they look like? So if they're rejecting a kidney versus a liver versus a heart, what does that look like? And then having a generalized idea of your anti-rejection meds. So for example, prednisone is one of them. So we'll go over that. But no, if nobody has questions for the burns, we'll start on organ transplant. I'll be done within the next maybe I'll give myself 30 minutes because I know myself. I talk a lot. Forgive me. Cool beans. Okay. So when we're dealing with patient teaching before a transplant, there are some responsibilities that they need to follow. What are they? Anything.
Stay as healthy as possible, exercise, eat right.
Yeah, stay as healthy as possible, avoid infection, and staying active is a big one too, right?
And carry a beeper.
I love the fact that it says a beeper. Like, I was like, bruh, I don't know anybody that got a beeper nowadays. That's some funny stuff. But yeah, staying active as well. Staying as healthy as possible means also staying as active as possible. So even if they are bedridden, if they have an ejection fraction of 10 and they have a LVAD or whatever the heck's going on, they need to be doing something. So like the isometrics, deep breaths, tighten, relax, range of motion, etc. Whatever they can physically handle to keep them as active as possible, because if you are more active, it also helps in your post-recovery period, avoiding that infection. So staying away from people that are sick, making sure that you get whatever you need to be done. I feel like that's the biggest one. I don't know about y'all, but like for me, is the second someone's sick around me, I get sick. Like I would be horrible with this. So avoiding infection, and and then the beeper. Um, what the heck are you doing? Do you need something? Put the broom down. What the heck? If you ain't gonna be cleaning, put the broom down. This man, I swear to you. But yeah, carrying a cell phone or a beeper. I feel like cell phone's more feasible nowadays. Because they will call them when the organ is available. They'll say, "Hey, we got a match for you." Like they're going to ask you, well, part of our responsibilities is avoiding infection. So they're going to say, well, are you sick? Do you got signs of infection? And then they're going to be asked to go to the hospital to prepare for the surgery for the transplant. They need to be, if I remember correctly, it's within 1 hour that they need to accept and be there. Like very quick turnaround. So they're very limited on like if they are healthy enough to travel, they're kind of limited on that. Hi, what's up? Okay, cool. Yeah, that's pretty much it for your patient teaching before and post-op. There's pretty much one big idea and a whole bunch of little subcategories to it. So what's your biggest piece of education you want to give someone post-transplant?
Take your medications.
Take your medications. Looking for signs and symptoms of rejection. Why is it important to take your medications other than rejection? Well, actually, it could actually cause never mind. Hold on. That question didn't make sense. Forgive me. What I was trying to get at was the patient's also at a large risk of infection because they're taking their medication. My bad. If they're taking, monitoring urinary output, monitoring kidney function or specific organ function of whatever organ they had transplanted as well is going to be very important for these patients. So we're going to tell them to basically try to not get infected from anywhere. Yeah, kind of same ideology as they were doing before to avoid infection, avoid large crowds, attempt to stay healthy, because let's be real, it's kind of hard. Watching out for opportunistic infections, making sure they're washing their hands, because some people don't wash their hands and I don't know why. Avoiding sick people, large crowds. And then this one, I feel like this is pretty important. Never, ever, ever, never, ever, never, never, never stop taking your anti-rejection medications, even if there is infection. Tacrolimus. I do remember him mentioning that, and we'll go over that down here in a little bit though. I don't remember where it's at. Actually, I just realized it's not even in my notes. I do remember him mentioning it in lecture though. That was one of the meds that you could use for anti-rejection. Yeah, I just realized it's not here. Okay.
No, I distinctly remember it.
Yeah, huh? Me and you both distinctly remember that. It's so strange. But yeah, never, never, never stop taking your anti-rejection meds, even if there's infection. I don't care. We'll deal with the infection. I don't want them to lose a kidney or a heart or whatever they had transplanted into them. If they're NPO, they still get the meds. So it'll be like NPO except meds. Be aware that medication can sometimes mask the signs of infection. So even a little thing such as a low-grade fever could be indicative of some kind of infection. Where am I at? Let's see. Da, da, da. Cool. Cool, cool, cool. And then we're going to go into the specific types of rejection. So what are your 3 types of rejections?
Hyperacute, acute, and chronic.
Darn right. So your hyperacute is what we're going to start with right now. Hyperacute, acute, chronic, yes. Why does a hyperacute reaction or rejection occur?
There's a incompatibility between, is it the ABO incompatibility
Darn right.
between the
Perfect.
donor and the recipient?
Yeah, this one is rare nowadays, but it does still happen. So you want to get a type and cross, make sure that you're giving someone the right thing. It makes sense. I'm not going to give someone with a, what is it, like a negative, a positive one? I don't know, just a thought. But yeah, so it can appear very, very shortly after. It can occur in the first few minutes and then up to how long after transplant. And yes, it does cause that blood clot in the vessels and then necrosis of the organ and graft. It cannot be stopped, unfortunately.
Unless you remove the organ.
Exactly. Oh, this is the Diego. This is the one where I was saying I was like send the to surgery.
Oh yeah.
Yes, barely happens because nowadays we do that type and cross to hopefully make sure we get it right. Know all your time frames for each one too. So making sure that you know that this one, because it's hyperacute, makes sense that it can occur just a couple minutes after, and it can last up to 24 hours after your transplant. Let's see. I think you guys mentioned pretty much everything on this one. Pretty straight up. Not too bad, right? Yeah. So ultimately, this one is gotta take it out. Say goodbye to new kidney. It's gone. Sorry, queen. Your next one is that acute rejection, right? So 1 week to 3 months after the transplant. Um, this one, this one is a bit of a different management. So what is your management for acute rejection? Just
Increase
realize it.
the medication dose.
Yeah, so it could be a change in dosing, right? Rejection. Sorry, I was trying to type that. There we go. So just because it happens does not mean that the patient will lose the organ. So just being aware of that. This is one where it's different from your acute, because the acute one, we can't do nothing about it. They're losing the kidney, they're losing the heart, whatever it is. This one, we can save it. I can save her. Signs depend on your transplanted organ. Yes, they do. We'll go over that in a little bit too. But yeah, definitely for your management in general for this one is your change in medication, maybe dosage, maybe a change in meds, yes, or change the med altogether. Pretty much just something going on with your management that's wonked out that they need to adjust. Very temperamental. Let's see. Here we go. This one, let's see here. Da, da, da. Here we go. I was on the wrong part. Okay. So very generalized education on this one is that they need to be aware of the signs of rejection because they're going to be going home, right? Like 2 months after the transplant, they're not going to be in the hospital still. They're going to be at home, chilling, watching TV, watching Honey Boo Boo Child, and all of a sudden it's going to be like, man, like I have this pain in my side. Oh my God, it kind of hurts. Like it's going to be, something that they should, yeah, maybe some flank pain, costovertebral. That was a big word. That was a big word for Elmo. Maybe they have pain in the upper right quadrant after liver. So, um, you know, looking at those things, and then we'll go over the specific organ ones in a little bit. But if there's anything where they even have a shred of doubt that, hey, I might be having some kind of rejection, that they need to be going to the hospital to be immediately evaluated and change the medication if needed to make sure that we don't lose the organ. That one's pretty straight up. And then your chronic, pretty much exactly what it sounds like, it's chronic. Why is this underlined? Give me a second. I'll figure this out. Why can't I be computer savvy? I'm Gen Z. I should be computer savvy. This is ridiculous. Okay. So this one is your most common one. Ultimately, this one can't be stopped. It's going to happen. It's just a matter of time. Your medications, smooth muscle around vessel, new organ, and occlude them. Crunchy. But yeah, so the fibrosis is permanent, no cure. No cure, exactly. So we're gonna have to make sure that, throughout the course of the time that they have this new organ, that we're taking as good care of it as they can, because ultimately we can't stop this from happening. So, your kidneys last 12 years. I don't think you need to know this, but this is just general. Kidneys last like 12 years, heart 10, lungs 5, pancreas 10. So ultimately, after that amount of time, you'll start to see some kind of failure again, and they'll need another one. There's no cure for this. It's Jover. I'm sounding like Diego. God help me. Yeah. So ultimately, if the organ's too messed up, you need another transplant. And we try to prevent that by having good immunosuppression and making sure that they're very good on their medication management. And that's just that. Okay. So we talked about like really general signs, right? So we talked about general signs um, of rejecting the organs, like pain at the organ site. So if you had kidneys, if you have some flank pain, that's a bit concerning. Or if you have right upper quadrant pain and you had liver transplant, like maybe something's going on. Just a thought, I don't know. Maybe some chest pain if they had, heart transplant. There we go. Brain's starting to die a little bit. Maybe I need a brain transplant. Who knows? Um, let's see. So these are like your really general ones. And remember that with your fever, it could be so minimal and it's changed from baseline. So it might not be like 102.7, 102.7. It might not be that high. It could be like 99 point something, but their baseline's 97 point something. Like that's a change, and that's significant for them, for that patient. So it could be something so minimal that you need to be watching out for them. And then looking at your specific organ function. So for your heart, what should we be assessing for your heart to make sure that that organ's doing all right? Pretty straight up.
Heart sounds.
Yeah, some heart sounds, maybe some like, are they having any kind of arrhythmia? Is there something where, I don't think you guys went over this, but is there something where like all the nerves and everything, they're not connecting properly and there's weird firing of electrical signals going on? Who knows? Um, Ultimately, is the heart doing what the heart is supposed to do? That's the bottom line of that. How is their perfusion? So anything perfusion related, right? Are they hemodynamically stable? What is their map? What is their cardiac output or cardiac index or whatever you want to look at? Is the heart doing the heart things? Is kidney doing kidney things? So what labs are you looking at for that? What physical signs and symptoms are you looking at for that? And that's just that. I mean, I'm pretty sure you guys know this. But yeah, liver as well. Like, what labs are you looking at for your liver? What physical symptoms are you looking at? Lungs, same thing. So I'll just put this down here. I need to make sure that Diego gets to his stuff too. I've been talking for too long. But yeah, so heart, hemodynamically stable. Kidneys, urinary output, 0.5 ml per kilo per hour is the bare minimum that you need. Looking at BUN and creatinine as well, seeing elevation in those can show you that this patient is not doing too hot. LFTs, is the patient jaundiced? Are they yellow? They should not be yellow. Lungs, how is their gas exchange? Looking at their ABGs, are they having shortness of breath, hard time breathing? Is there anything that looks to me like maybe they're not doing too well with their new lungs? And then for all of these, I mean, vital signs, you're never going to go wrong with vital signs, right? It's vital. So monitoring your vital signs, and your map is always a good indicator of organ perfusion, which is why it's so heavily emphasized for this class. Please look at your map. Please calculate your map. And then last but not least, having a general idea of anti-rejection medications. And ironically, I know you said oh God, what was that meant? Yeah, I was like, I had to scroll back up to find it, tacrolimus, but ironically, in the notes and in the PowerPoint that he gave to us, that it's not there. So I'm kind of like, oh, that's kind of odd. But yeah, it's you don't have to know too deep. You don't have to know like the specific pathophysiology of each one. Just have a general idea of some of the meds that you'll be seeing. So like steroids, somebody mentioned it earlier. Prednisone's a good one. I don't even know how to pronounce this, but I know the med that's there. Calcineurin inhibitors. A good example of that is cyclosporine. That's a common one that I've seen. Anti-proliferative. So Imuran, I've seen that, and Cellcept, I've seen that as well. Monoclonal antibodies. So anything that ends in mab, mumab. And your polyclonal antibodies, which are pretty much the exact same thing as your monoclonal for purposes of this class. There's differences, but you ain't gotta know it that deep. So having just a very general idea of like, oh, what meds fall into this? What does this med do? You know? I don't think you have to know that. Just knowing that it's part of your anti-rejection med should be enough. So yeah, just making sure that you familiarize yourself with the names of each of these medications. That's not a medication. There we go. Oh, they didn't listen to you. But yeah, that's pretty much it for your organ transplant. I know that there's a lot of other stuff that was mentioned in your lecture regarding, how transplants are found, or like how they match people together, the organizations and whatnot. But I feel for the purpose of for this class and for a lot of your nursing interventions, you should be focused on the rejection, pre and post-op education, what to look out for is what really essential. I'm so sorry. I just looked at the chat right now. If you're talking about like the organizations and stuff, no. Okay, yeah. Because, when it deals with that, you have a very special organization that deals with that. So technically, us as registered nurses with no additional certification or license or whatever it is, we can't speak on organ transplant. You have to call in a team to do that. So that's why it's like, you don't really have to know it as common knowledge. You kind of just have to know, oh, I need to call someone for organ transplant, and they deal with it. We do have to know because you will have patients come in and they have kidney transplant, or they have um, heart or lung or whatever they had transplanted. So we need to know how to take care of it after the fact. So giving those meds, I don't care if they're NPO, it's NPO but meds. They can have meds. Making sure the order says that, making sure that's okay. If they're not eating or if they're not doing whatever, they still need to be getting their meds. If they're sick, I don't care. I'm sorry. They're getting their meds because I can deal with the sickness, but I can't deal with them losing the organ. Sorry. Just stop it. It's starting to sink down with the sickness. But yeah, that's going to be the main things. Is it's really heavily focused on what are you looking for after, so your post-op stuff, and then how do you care for this long term. That's what you need to be focusing on for the most part. Pretty much the stuff that I put on this outline is what you should be looking at for the most part. Cool, cool beans, cool beans. And now it's your turn. I've been talking for too long, and he's gonna go on to HIV and talk about some HIV things with y'all.
Alright, yeah, go ahead.
I had my legs crossed too long. The hips hurt.
Alright, mom said it's my turn on the Xbox, so. What? Oh, I left some food, yeah. I'll finish it. Somewhere. Okay, so, I'm just gonna try to break this down into essentials and, not waste time on like stuff that you definitely don't need to know, stuff that, gets thrown in that's kind of fluffy and extra. Um, let's just talk about HIV. What is the condition mostly based on in terms of like assessment? Like what lab or what value, what thing are you looking at to kind of guide
Your T cells. Okay. Yeah. Your CD4 T cells. Yeah, basically. That's as far as you need to know. Is there more nuance to that? Yes, there is, but you don't need to know it as particularly far. And yeah, less than 400. Okay, yeah. So that's especially when you start to see levels. You'll start to see like more symptomatic symptoms and stuff. Um, or yeah, this is symptomatic. Sorry, more symptomatic stuff happening, etc. Yeah, so immune problems begin when levels drop to around, we mentioned, yeah, about 200 to 500. It kind of falls in that range of, because I think one of you, yeah, Josh mentioned AIDS at about 200 less. So you'll start having issues with your immunity around 200 to 500. And when it falls under this level, then it's gone past just normal immune problems and goes down to um, advanced issues, which is with your AIDS. So in general, HIV is defined by, um, so you guys kind of already talked about it. We talked about CD4 gradually declining. You mentioned the immune levels. There's like different stages that were mentioned, but you don't really particularly need to know that other than really focusing in on that, probably that 200 mark. But other things that I think are good to know about HIV, and this is as most patho-like as you'll really need to really think about. Um, this is what happens to the macrophages? What about antibodies? Tell me about those. Just kind of blurt it out, and we'll just kind of.
Bodies are going to increase, which is going to decrease the viral load, but then opportunistic infections will eventually make the viral load increase.
Right. So you have opportunistic infections happening. For the most part, your opportunistic infections are extra common in AIDS. So I would say AIDS is defined by the presence of, not to say you can't have it, so but infections and cancers. What about macrophages? What about antibodies? It's just like HIV. This is as much patho as you need to really know. Macrophages is related to like immunity. What do you think happens to those macrophages? Yeah, they just stop working. As simple as possible. They stop working properly. What about antibodies? Another part of your immune system. Do you think this condition's gonna make them work normal? What do you think is gonna happen to those antibodies?
They're going to be overwhelmed too. And stuff.
Yeah. So they're also gonna be ineffective. They're not really gonna be able to properly function. And then how does HIV replicate?
In the cell's nucleus with it
Exactly, yeah.
binds with the DNA, the host DNA.
Yeah, essentially, yeah. Your HIV is essentially taking your immunity hostage. It's using your own cells to replicate. This is as far as you need to know for any deep path. This is as far as you need to know. So, that's it. That's all you really need to focus when it comes to the concept of that. Nothing in more detail than that. You don't need to know about you don't need to know about no um
First transcriptase.
yeah, no, none of that. You don't even need to know like the way it's able to get inside the cell. Don't worry about any of that stuff. Just that's as far as you need to know. And all of this you can kind of just rationalize. Kind of makes sense. Immunity work less, immunity work worse. The thing we're using to measure, it gets worse. The only thing that maybe wasn't gone over too much is, and this is maybe like a more well-known thing about HIV is that it uses your own body to replicate. That's as far as you really need to go. But we mentioned AIDS. You've already mentioned so your CD4 less than 200. That's a good way to. That's kind of when AIDS is officially diagnosed. That's the definition of it, and that's when you'll have a lot of those opportunistic infections and cancers. Common things you'll see with AIDS are people having oral thrush, having pneumonia, different types of pneumonia. Cancers are also likely. And in general, when people have AIDS, they're gonna have a very weakened immune system, which also means they have a very weakened immune response. So this kind of similar to when we talked about liver. If you guys remember when we talked about liver, it's people with like early liver disease, they'll have an elevation of like the liver enzymes. But as that like liver cirrhosis starts to get really, really bad, it gets to the point that those enzymes aren't even being made much anymore. And the liver enzymes will either be normal or low in the blood. Do you guys remember that? Do you guys remember that kind of concept where like again just trying to relate it to a different thing we learned? Liver, when it's early, it is damaged or starts leaking a bunch of enzymes. That's when you see the enzymes go up. But then later on, when it's really, really bad, that's liver cirrhosis really bad, the liver can't even make those enzymes, so it doesn't show up with elevated LFTs. So we can kind of relate that to AIDS where the immunity response is so bad, you're like pretty much not even getting anything. So for example, you might have like if you were to get like a TB, you get the TB screening. It's possible. I think if you guys remember the little numbers for TB, if 5 or less can be considered abnormal with someone with HIV or AIDS and whatnot, it's possible that they might not even have a reaction, period, because their immune system is so weakened that they don't even react to it. So at that point, that TB test is not as helpful for that, and they have to probably do like a chest X-ray and yeah the little blood test or the blood cultures. The was it the fast? What was it the acid fast thing times 3? Yeah. Do you guys kind of get what I'm getting at? Just a very weakened immune
Yeah.
response.
Yeah.
Yeah. Yeah.
I have a question.
Yeah.
Can the opportunistic infections and opportunistic cancers also be affected in HIV?
Yes,
Okay.
yeah, they can definitely show up, but again, it's more likely to happen with AIDS just because the body has like literally like very little thing to fight back. Um, but yeah, it's kind of like, for example, when we think about um immune responses, we think about like fever and stuff. That's your own body doing that. Your body does that for a purpose. It does that to try to fight back against the infection. So that's that. So people with AIDS might not present with much of yeah, yeah, yeah. So they might not present with much of a fever. They'll have maybe a
Oh, I
low-grade fever, for example. And this actually applies to older people as well. Just as we get older, we have weakened biological reserves. Our reaction to things are less. So a weakened immune response leads to less reactions, which leads to less fever. Um, so that's something.
Okay, I think I kind of understand what you're saying, but is it like if they have HIV, they'll still show signs and symptoms of opportunistic infections, but when it progresses to AIDS, they will not show signs and symptoms of that infection because the immune system is so suppressed.
I mean, they'll show like the symptoms of like disease, but they might not show like the fever as much, or they might not have some certain reactions. So like the TB test, it might not show up, and it might not show any induration. That's kind of what I'm getting at. It's just they might have like low grade fever at most, maybe like not even much of a fever. They might not present with some of the typical things we think about with infections. They'll probably have some things like that. Weak to no response to TB skin test, the PPD. All right. But what is our goal for treatment of HIV?
Increase the viral load,
Yeah.
increase the CD4 count.
Yeah, so essentially, yeah, increase CD4 count, decrease viral load, and we are able to get this viral load to essentially undetectable levels with proper management. But that's kind of it. That's all we really need to focus on and not go too much deeper than that. When it comes to some diagnostics that can be done, we already mentioned that we'll probably be looking at WBCs, CD4 T cells, and we kind of already know what's normal and what's abnormal for that. Is there anything else, maybe like two or three things in particular that we're thinking about that could be done to assess?
What a HIV antibody test,
Yeah, what's that called?
right? Antibody test. I don't know what it's called. Sorry.
Yeah, I'm sure if you saw it, you'd recognize it. A PCR is one.
Oh, wait,
Yeah,
what? Eliza?
uh, yeah, ELISA. Yeah, so ELISA like that. So
Mm.
that's essentially it's there to detect HIV antibodies. If your ELISA or yeah, let's just call it that. If your ELISA is negative, does that necessarily mean you are HIV free? Yeah, so depending on when they take that test, it might give you false negatives because there's that window period. So it has a window period where it can give you false negatives. If a test is done too early. So it's something to keep in mind that this person, even if they're considered HIV, if considered their ELISA comes back negative, that they should still be properly assessed. They should be educated on safe sex practices and things like that. They'll need to come back and get another one done just to make sure. But the most important thing is to make sure that the patient doesn't just assume that they're free and potentially infect someone else. So it's still important to make that assessment and provide that education. Make sense on that? And then we talked about PCR as well. This is kind of a test for viral load. So we can see how much is kind of going on in the blood. And again, the goal is to be undetectable if possible. And this is a good test to see how patient is doing on their treatment as well. So obviously a high viral load is not a good thing. If that viral load goes up, it could either mean that that HIV is becoming drug resistant. It could mean that maybe they're not very adherent to the treatment for many possible reasons, because those medications come with a lot of side effects and it can become not very tolerable for some, and they just stop taking it. Um, But a lot of those signs and symptoms should go away after your body gets used to them and minimize over time. Okay. So here I have some of the probably like the main three things here, as well as just like general education. But let's go through wasting syndrome. Kind of what is that? What is the definition of like a wasting syndrome? Okay. Josh mentions it's a weight loss greater than 10%. Yeah. Don't focus too much on the pathogen, just really weight loss of like 10%. And where does this weight loss kind of come from?
What's the weight loss? Oh,
Y- Yeah, a lot of diarrhea, a lot of potential vomiting diarrhea. So what are some things that we're thinking about when we hear that our patient is essentially vomiting and having diarrhea?
electrolytes.
Yeah, a lot of electrolyte loss. So um, that's going to be one of our interventions, right? How do we treat that? We just have to make sure that they're drinking enough fluids. And what else are they losing with diarrhea, vomiting, etc.?
Nutrients, vitamins.
Yeah, Electrolytes, yeah, electrolytes, vitamins, that's good. So we can replenish them. We can assess what's going on in the like what lab values, calories. That's a good one. They might not be tolerant of food. They might, and they're losing weight, right? What is our goal overall, though? Is our goal for them to get the proper amount of calories in this specific day? Uh, yeah, very specifically. And he mentions this in particular. The goal is to maintain weight or gain weight. It's not necessarily to eat the right amount of food in that one day. It's kind of like a long-term goal. So we want to gain or maintain weight. So watch out for that wording on the test. And speaking of that, so how do we gain or maintain weight? What else can we do? We talked about dehydration. We talked about replenishing electrolytes. Okay, TPN could be done, but is there anything we can do before we have to go to TPN? Okay, so yeah, yeah. Kaylin's saying like lose it, use it or lose it, and that's kind of the idea. So if you're not using the enteric route, your PO route, it can lead to certain things like translocation of bacteria. Basically, you're gonna want to, if you can, oral, then you do oral. So yeah, high calorie. So high calorie specifically like protein. We're talking maybe like about over like maybe like about 5,000 plus calories or so. We're talking about high protein, frequent small meals. That's always a good answer. Of course, yeah. And yeah, anything else that kind of goes with wasting syndrome in terms of signs and symptoms? The main one's probably like diarrhea. Mouth care, oral care, yeah. It's gonna help a lot with making it more tolerable to want to eat. If I'm vomiting a lot and I got kind of like all that acidity in my mouth, food's probably not gonna taste very good.
Absorption problems.
That's possible.
You can get lesions too.
You can get
Or
what?
lesions.
Oh
Oral
yeah, yeah, for sure.
oral.
Yeah, right. And that makes sense, right? When we were in 230, we talked about like bulimia, like the kind of stuff that happens when you're purging. So if you're constantly vomiting, that can also cause like damage to your esophagus, damage to your teeth, and whatnot. So we're gonna say also chronic weakness kind of goes with that dehydration. It goes with that loss of electrolytes. Another thing that seems maybe slightly random is that we do have a fever that lasts a long time. And again, depending on how immunosuppressed essentially they are, this could be like a low grade, most likely like a low grade fever than anything. It is caused by a pathogen, so the body is still reacting in some way to what's kind of going on. Any questions on that? Again, this kind of just falls down on ABCs, fluid replenishment, electrolyte replenishment, calorie replenishment. All right. So next there is the some other opportunistic conditions is the PJP. This is the a specific fungal pneumonia. A lot of the opportunistic conditions end up being like fungal. So for example, this one is fungal. Oral thrush is fungal, but don't worry too much about it. It's just kind of worth kind of mentioning. Spread to other organs. Prone to pneumothorax. That's true. Well, kind of right down into complications. Uh, uh, Pneumonias in general can lead to pneumothorax, so that's something to kind of keep in mind or kind of think about. What are some signs and symptoms? And I know they can be a little vague on your signs and symptoms. It might be easy to confuse it with other stuff. Yeah, so like dyspnea, shortness of breath. Yeah, tachypnea, shortness of breath, tachypnea. Okay. So we could have, yeah, lungs, this kind of a we call adventitious lung sound. So we can have abnormal lung sounds. So you might hear more like coarse crackles or rhonchi. A fever, yeah, like another like a low grade fever typically. Anything else? So if we have fluid in our lungs, what might the person just do naturally? What does the
Oh,
body do? It's gonna cough, yeah. And in particular, they say this is like a non-productive cough. Yeah, the sputum is so thick they can't even cough, which can be just for because I know like these signs and symptoms are so vague and you can get them confused with different pneumonias or like tuberculosis, for example. From what I've done, like research, here's kind of what I have information on. This is like typically the case here. So non-productive cough, mucus is so thick that it does not get coughed out, essentially. Yeah, tuberculosis typically we have blood tinged sputum. In typical pneumonia, you could have rusty sputum, which is kind of referring to old blood, while TB can have like bright red blood tinged sputum. Just extra information to help differentiate because they are very similar looking. Okay, how do we treatment is Bactrim or Septra? Yes, so that's your TMP-SMX. So interventions, that's gonna be an antibiotic. So that's your TMP-SMX, which is your Bactrim. And there's also Septra. Actually, I don't know which one's which. Let's see. Bactrim. Yeah, so that's the TMP-SMX, which is like trimethoprim sulfamethoxyl, whatever. Is usually the short. That's usually how it's shorthanded. I would just remember Bactrim. Don't worry about conserve energy. Yeah, so if they have all of this going on, similar to we know how to treat people that have these pneumonia and whatnot. Having them conserve energy is good. If some of these people are having, for example, I think something we didn't mention is like night sweats. They're having what? Oh, yeah. If someone's having like night sweats, they're having fever, they're having a high respiration rate.
you can do oxygen therapy too.
Sure, yeah, we can for sure do that. We can give them O2, supplemental O2. But yeah, on top of all that, if they are breathing a lot, they're having fever, they're having sweats, what else might they be losing?
Yeah.
What was that? I couldn't hear it.
It's-
You said fluids?
Yeah.
Yeah. So they could have fluid loss from like the insensible losses. That could be something to kind of think about. And even though they might have those crackles in the lungs, we do want fluids with these kind of people because it helps to thin out the secretions. We saw that like one of the problems with this person is that their mucus is so thick. So if you guys recall all the way back then for like general like pneumonia, that is a intervention is just getting them the proper amount of fluids to thin secretions. Maybe they could reposition themselves so that they can expectorate things. Um, there's
Would,
chest physiotherapy.
would mucolytics help with these patients, or is that gonna suppress their immune system even more?
Um, I feel like it would help them. I'm not sure if there's like a particular relationship between the mucolytics and like immunity. Let me check.
Doesn't the mucolytics it acts on like the histamines or something, and so that's
Let
how
me see.
that plays in with the.
Let me see
Or is
exactly.
that something else?
Let me see. From what I can tell, that's not their typical work, because the mucolytic works through like it's not an antihistamine, as far as I can tell. I mean, well, I would have to look that up. Let me see.
Is it or it acts through the goblet cells or something?
Da, 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 da.
The thing that secretes.
Yeah, I don't. I don't think there's a relationship, but again, we could look that up some other time. I wouldn't really worry about it. At least for this test, we don't worry about it for this. Yeah, what could be some diagnostics? I don't think it comes up, so I'll just type it down to save us time. Sputum culture, that if we can get a sputum culture, or again, if we're not able to get something, we can kind of do a scrape of the inside of the mouth. Or if we're able to suction, we can suction out any secretions as long as we have a brand new clean canister, we can do that. A lung biopsy could be a way, but yeah. The main thing is your pneumothorax is a complication. Yeah. That's pretty much all there really is to this one. It's again it's a type of pneumonia, so we do have a lot of knowledge. Was this exam hard? Trying to think. I think this was one of the easier ones, actually. I think you guys did all the hard ones already. Yeah. I feel like this one was definitely easier than the other ones, and then the final was easier. Yeah, I felt like it was. I definitely felt like it was easier. Now, it doesn't mean don't study. It doesn't mean don't do all the stuff. Don't step off the gas. Don't step off the gas. But yeah, have that secure, a little bit of like hope, like a little bit of hope, because yeah, you're almost done, and this test should be easier for you than the other one. So
Did their graduation petition, right? I'm just asking because the school sometimes takes a while to do it.
to treat a patient with Kaposi sarcoma. Oh, interesting. In clinical or in your job? Ah. Speaking of, I guess we can just kind of go to that as well. How long have you been in LVN out of curiosity? And whoever wants to answer this, I mean, the main thing to know is just like an opportunistic cancer.
Yeah.
Decade. Wow. And I have a picture that if you guys want to kind of look at what it,
No thanks. I don't need. Oh God.
yeah. The main thing you really is you can kind of see what's going on. You have these purple spots on the skin, and it's painless. It's painless lesions. Okay. It's caused by human herpes virus 8. Don't worry about that.
Non-infectious, I think.
It could be spread to the same way. Community HIV clinical. Interesting. Usually it's contracted through sexual contact. Don't worry too much about it, like all that stuff. The main thing you would just really need to know is some of the treatment and some of the things that to think about with this. So, for example, how can we treat a cancer?
Chemo.
Yep, so pretty much always going to be those for the most part. If you're able to excise it, then that's also an option for certain ones. But the main thing really with this one is I want to talk about some of the precautions when it comes to this. Is this a contact precaution? Is this a drop? Is this an airborne or something? Is like just having it out gonna get you? What do you guys think? Yeah. And what does it mean to have standard precautions?
Wash your hands.
Yeah, essentially, yeah. Like you're basically like you come into the room, you hand hygiene, you put your gloves on, done. That being said, though, something that I think is worth really thinking about is let's say somebody has Kaposi sarcoma and they have like a wound somewhere else, and you're kind of cleaning that area of the Kaposi sarcoma, and then you're moving on to the wound care.
Yeah, change your glove in between.
Yeah, make sure you change your glove. Definitely wash your hands. You don't want to kind of cross contaminate because cross contamination between different wounds and different stuff. So definitely, it's gonna have standard precautions, but we're going to make sure to properly eliminate kind of any soil dressings. We're gonna make sure to avoid cross contamination. a lot of the stuff that makes sense, right?
For auto contamination.
Yeah. Essentially, that's pretty much all there is to it. But just keep in mind that this is just standard precautions. Okay. And then what's this education? The education tab is just kind of like in general. What are some important things that are in general good for someone that has HIV or AIDS to know for their safety, for other people's safety?
Safe sexual practices.
Yeah, yeah, like that. Safe sexual practices, use protection, can help to avoid, STIs and it is when we get that viral load to undetectable levels, it is technically possible for them to be able to have sexual relationships without protection and not infect people, but in general, it'd be best to do it just for safety's sake. But that's kind of like, with the modern, yeah, even though it's yeah, exactly. Although it's technically possible. But yeah, it's possible for someone that to get their levels undetectable and then have children and have the children be HIV free. So like modern medicine has made that advancement. Anything else do you think is important? So patient, and this kind of goes with just like general neutropenic teaching, education, immunosuppressed teaching. Yeah,
Um,
take your meds, sure.
don't change the cat litter box.
Oh, true. Well, why are you trying to avoid the cat litter box?
Is that what's it called? Toxoplasmosis gondii.
Yeah, the toxoplasmosis. That's something that yeah HIV people with HIV are far more likely to get. It's not it's an opportunistic infection. Um, so I would say also don't stop abruptly in general, and you can kind of just apply that to most things. Don't abruptly stop taking your meds. Um, so what else for immunosuppression? These people are at risk of pneumonias. So what's a good way to do your best to prevent pneumonia? Let's say they're at the hospital, they're there for like a surgery or something, and they're resting in bed.
Avoid sick people.
Yeah, avoid sick
Don't
people.
share
Yeah,
your personal items, like toothbrushes or something.
yeah. And then this one comes up, I guess, a little bit more with like your Kaplan and stuff, but kind of don't share room with patients with infection. Makes sense. You'll have questions where it's like, where can you assign this patient? Does this patient assignment with this neighbor make sense? You'll get that for like Kaplans and stuff. I would also add because they're at risk of pneumonia and stuff, make sure that they're doing their turn cough, deep breathe because they don't want to build up that fluid from not moving around too much. And then if they have infection, it could get infected and more pathogens can start kind of chilling in there and cause pneumonia. In general, maybe think about like neutropenic precautions, like we mentioned. And here's one that always comes up with neutropenic precautions is vaccinations.
No live vaccines.
Yeah, avoid live vaccines. And this is something you'll probably need to learn for the NCLEX, but it's just kind of MMR, varicella, I think smallpox. Yeah, especially if your T cells are under 200, yeah, which is AIDS.
Also, no flowers in the room and
So it kind of goes with
no
this. So
pets.
avoid like raw fruit, pets essentially, raw fruits, pets, flowers. Same kind of concept. Any questions on what we talked about? And then I have some questions I wrote as well. So kind of to go back up and reminder, everything's based on your CD4 T cells. Immunity, AIDS is defined by that CD4 under 200. Patients with this are very prone to the opportunistic infections and cancers. They have a weakened immune response. Their body is struggling to even respond. So they might not even have a reaction to the TB skin test. So it's not the most reliable thing, and we can't just take it as like, oh, that's a negative, right? We gotta treat it as if this patient might actually have TB. which I don't know if I have a question about that somewhere in there. We'll see. And yeah, HIV is defined by some of these things that make sense. Antibodies and one of your white blood cells aren't going to be as effective. HIV replicates using your own body, and your C4 is declining. That makes sense. I think it's important to keep in mind for the ELISA that there's that window period. So somebody being negative doesn't necessarily mean they don't have it. It could be a false positive. What's important though is that you provide the proper assessments and teachings, make sure that they're practicing safe sex still, because they might actually be infected. It's just it doesn't show up yet, and they'll need to retest. But the most important thing is making sure that we assess the situation and whatnot. Follow that nursing process. We talked about wasting syndrome. Your goal is to gain or maintain weight, not just our goal is for them to eat 2,000 calories. Our goal is for them to actually keep the weight up, alongside making sure they're not dehydrated, making sure they're not losing too much potassium, for example, and being able to actually get food down. So small, frequent meals, high protein, high calorie is going to be key to actually doing your goal. Talked about PJP, some of the symptoms. It's easy to confuse this with pneumonia, but a lot of stuff you've seen before because it's pneumonia still. Let's say hydration, tooth and secretions, all your stuff that really makes sense with pneumonia. The key takeaway for Kaposi sarcoma again is that standard precautions, avoid cross-contamination. And yeah, and all this education here. Yeah, it's pretty simple. You don't need to know too hard detail. I would say, Killen's, I'm sure mentioned already, your biggest focus is probably going to be on the burns, and then just having a good understanding of um, how to assess and manage the organ transplant reactions and whatnot with complications. All right, any questions? And otherwise, we can move on to questions. And I'll try to get you guys out of here quickly. All right, so here is there's only gonna be 8 questions, but I think it's like 3 burns, 2 organ, and then 2 HIV, maybe like 4 burns, something like it adds up to 8. Number 1, a 30-year-old patient with 40% TBSA burns, including deep partial thickness and full thickness burns, is receiving fluid resuscitation per the Parkland formula. 8 hours after the injury, their blood pressure is 90/60, their heart rate is 125, urine output is 15 mLs per hour, and their CVP is 2. Despite increasing IV fluids, the patient remains hypotensive. Which intervention should the nurse anticipate next? All right, so yeah, so this one, and this was contentious because we got A and we got some B's. So how about we have whoever thinks it's A or B, what's your rationale? And we'll talk about it after.
So I'm thinking A because albumin is what maintains osmotic pressure in the vascular space, and that would, you know, what's happening patho-wise is things are leaving the intravascular space.
Mm-hmm.
So you want to increase the albumin so that to prevent, to stop that from happening.
Right.
Alright.
So right now we have what, a CBP of 2. That means what? Does that mean they're dry, they're wet?
Means they're deficit.
Yeah, there's deficit. But we're giving them fluid. So where's this fluid going? What happens with burn? What's the burn path right there? Where does the fluid go?
The interstitial space.
Interstitial. Uh-huh. So yeah, so the answer is A. We want to give albumin because right now the main problem is they're getting fluids, but it's going into the wrong space. So the pressors, we don't have enough fluid to work with. So those pressors are, pushing down, but there's not enough fluid to actually play with. I think we might have had a question similar to this in like a previous tutoring session where we had like a low CVP, and it's like what would contraindicate the use of pressors, and that was that they were still kind of dry. Um, so like don't use pressors before we give IV fluids because it's essentially less invasive, and also the problem is the lack of volume rather than the amount of pressure. So here there's a lack of volume, but we're still putting fluids in, just the fluids is going to the wrong place. So the albumin is going to help put that fluid where it's supposed to be back into the intravascular. Does that make sense for everyone? All right, cool. Made you think there. And this is an example of how you could like intercorrelate different concepts for like a test question on like a final, for example. All right. Number 2. Oh, sorry, did I skip one? No, never mind. Number 2. A 45-year-old patient was trapped in a house fire and has burns on the face, neck, and upper chest. Upon arrival at the ED, they are alert but have a hoarse voice, cinched nasal hair, soot in the mouth. Their O2 is 96%. What is your priority? All right. So what's the rationale between, so we have C versus A. So what do you guys think? What's the rationale between both?
Any sort of burns on the face or neck, upper chest that is very close to airway, and the airway has a tendency to swell rapidly when it's has trauma.
Okay.
So you want
Right.
to intubate them early so to prevent it from being obstructed.
Sure. What about the SATO2? What do you guys think about 96%?
Yeah, that is also a concern. However, I feel like
Mhm.
you could do that after, like you can get the ABGs after you secure the airway, right? Because
Yeah, essentially. Remember how when we were kind of
they
in that ABG? Yeah, an answer C just for before I gap. You guys remember when we were going into the ABG? We were like doing vents ABGs. So and it was kind of like when are we doing the ABGs on this person that's decompensating and then waiting for the result? We're just gonna act. Um, in this situation, I think we have a decent enough amount of assessment. We know that they have burns in those areas that can cause swelling. We also know that they have cinched nasal hairs and soot in the mouth. It's very likely not only is their airway potentially closing, but it's also very likely that they could have carbon monoxide poisoning. Um, and in this situation, it's kind of like we're not gonna we're not gonna get ABGs and then wait to see the results and then to make an action. It's just kind of
Instead.
so if you guys remember, so where is that so they have burns in their neck and their face and their upper chest. What can happen in that area due to the burns? What, what happens with the burns? Can have swelling. So the recommendation is that if is to try to intubate before the swelling gets so much that you're not able to put the tubing down the throat. Does that make sense? Or not the throat, but the airway. So you want to beat out the swelling. I get that. So I think you might have mentioned it too in your guys's either
In the
lecture,
PowerPoint.
PowerPoint, yeah, that yeah, the airway could swell, and if you're not early enough, the swelling might beat you to it, and you're not able to get that tubing down, and then it's just like it's over. So in that situation, you just have to act. It's kind of where like you use your your gut feeling. Plus, you do have like if you see like these words on a NCLEX or something, you know, like you pretty much know what they want you to think about. In this situation, like the soot in the mouth, the singed nasal hairs are like classic signs of possible like a CO2 like possible CO2 poisoning or airway like impending airway closing. So usually if you see these on like a test question, the idea is that they kind of want you to start thinking about airway closing, CO poisoning, and early airway management because it could close and it might be too late if you delay treatment.
There's a really good video on Kaplan channels that
Uh-huh.
explains this question like to the T. And yeah, so I recommend anyone check that video out if
Yeah.
you
Yeah. So in general, yes, even keep in mind they do have like yeah, it's because of all these, even though they're not currently in distress, you just want to beat it to it. So you will try to do early intubation. It's just kind of like the safest approach, yeah. Okay. I haven't done these in a while, but like open discussion in burns. Let's just do burns. So what are some things that could go wrong with burns that we talked about or you guys talked about with Kaylin? Infections, yeah.
it's a
Fluid shifts.
circumferential burn. You could have compartment syndrome.
Yeah, exactly. So I'll write these down. So you guys mentioned, yes, sure. Fluid shifts, hypovolemic shock, fluid shifts, shock, like shift shock. We can call it that. What else? Compartment syndrome, of course. Yes. We've mentioned already infection. We mentioned airway, like airway blockage. This one's kind of random. Obviously pain. I know pain. This one's kind of random, but these people are like highly stressed. So what's something that could come?
Hyperglycemia due to increased cortisol stress response.
Like, is it hyperglycemia?
Yeah.
Yeah, that's possible as well. Sure, we can add that in there. It's worth keeping in mind for sure. Anything else that might occur? And maybe you guys have done, now that you guys do IV pushes, maybe you've done like an IV push for prophylactic for something that's caused by stress that you might have to have reconstituted. A PPI, yeah, Protonics or an H2 blocker for stress ulcers, right? So stress ulcers are something that so yeah. So that's kind of that. And let's talk about we go into a lot of detail when it comes to the fluid shifts, the shock, the compartment syndrome. Let's talk about like two in particular. So for example, we talked about yeah, protonics, so stress ulcers that comes with like protonics. Um, and let's look at the generic. I believe that one is the pantoprazole. And then so a lot of the I'll just do PPI and H2 blockers. So PPIs, H2 blockers. So PPI, those are usually the Prazols. Does anyone know what the endings for a lot of the H2 blockers are? Yeah, yeah, like like Tadine. So like, well, meprazole. Protonics was pantoprazole. So examples here. So this could be famotidine, cimetidine. So for example, and if and this is kind of like, if you're in clinical and you have these meds, a lot of time it's because of prophylactic for stress ulcers and stuff. So I know it's like a common. Sometimes they get these like prophylactically and it's like a PO. So I've seen like some be like, oh, what's this for? And like the student will be like, oh, it's for your GERD. It's like, I don't have GERD. Like, what's GERD? I don't know. What is that? Right? So it's like knowing your indications for what's going on here. Stuff. Yeah, so just know your indication, understand your patient teaching because they'll ask you about it. And if you kind of tell them, oh, it's for GERD, it's like, what's that? Well, I don't have that. Why are you giving it to me then? Right. So yeah, it's for stress ulcers. Okay, so that's all I got for the burns. The Parkland formula, I think maybe you'll have like one question on that. So not Parkland formula. I'm sure you will have at least one. The rule of nines, you'll have at least like one question on that. On the final, I do think you have like maybe one or two on that. So if you guys feel like you want to practice that more, maybe we could do that in Skills Lab tomorrow. If you guys kind of want to go through some of that. Um, and then we'll do number 4. A patient who recently underwent a kidney transplant 4 days ago presents with decreased urine output, hypertension, and an elevated serum creatinine. A biopsy was done to confirm the disease process. What is the most appropriate initial treatment? And what do you think? What do you think is the disease? Like, what do you think is happening in this scenario? So, kidney transplant 4 days ago. They're coming to the ER for they're not able to pee very much. Their
Acute
blood pressure was
rejection.
high. Which one was it?
Acute rejection.
Acute rejection. Okay. So what do you think is the proper treatment for an acute rejection? What was it? B. Okay. You guys agree? All right. So yeah, this is a B. So the other options, increase fluid intake and monitor kidney function. Um, in this scenario, like it doesn't address the immune response. So we really want to focus in on that rejection. So it kind of requires you to recognize that this is a rejection. You got to do something else other than just this. This would be C would be counterproductive. You're gonna make it worse, so you're definitely not doing that. And nephrectomy, when would we do? When would this be appropriate?
Hyperacute.
The hyperacute. Yeah, exactly. And then there's also another one. There's it's not an answer choice, but it's like chronic. If the patient has like a chronic rejection, do they necessarily lose the organ? Like, yeah, at least not immediately, right? Like over time they might, but not an immediate thing, right? So, what about with an acute rejection? Do they lose the organ with acute, like guaranteed? It's rare, yeah. It's mostly the hyperacute where it's like, okay, if we don't get this out, your body's gonna go into like a cytokine storm for hyperacute. But for regular acute, usually, yeah, like here the increase of change in medication is appropriate. All right. Number 5 is a SADA. Patient who just received a kidney transplant develops anuria, so no pee, hypertension, graft swelling within hours of reperfusion. What is your interventions for this scenario here? And then what is happening here? So there's a SATA here. So at least 2 answers. Yeah, so I'll wait for a few more people to put their answers, and then we'll kind of go over each letter and then talk about it. And keep in mind, this is about the health team as a whole. Right. So you guys, so Michelle mentioned what's happening here is a hyperacute. So within hours, up to like a day, up to like a day would be considered a hyperacute. So this patient, I think a lot of us were able to. Gee, not too many people put. So let's go over A. So A would be administer high dose corticosteroids to suppress immune response. I see where that confusion came from. Yeah, it could be like up to like a day. Yeah. Could be from minutes to like a full 24 hours. Yeah. That might, does that change your answers? But yeah, let's talk about A. So A, what does this in the scenario where it's a hyperacute, is A going to help with this?
They know because the body has already recognized the organ as non-self, so it
Yeah,
will just
exactly.
make it worse.
Yeah, exactly. So like A is good for the acute reaction, but for a hyperacute, it's just a different pathophysiology. It doesn't really help it. Doesn't really help with the causes. It's a lot of times caused by like preformed antibodies. Um, I think he mentioned the patho. You don't have to know it. Don't worry about it. But just know that this is more for like an acute response. So it's not going to be your treatment. A lot of you were able to actually get B, which is great because that's actually one of the answers, B. So we know that hyperacute, the patient is not going to be able to keep the organ. So our interventions are really going to be getting that implanted kidney out and then essentially doing a plasmapheresis and IVIG in an attempt to kind of work around the immune system. It helps to um, pro- uh, remove some of like the antibodies, and it's going to uh, help with this particular situation alongside the actual removal of the kidney here. C says increase IV fluid to administer diuretics. At this point, that's not your priority because at this point, it's like, sorry, you're gonna have to get another kidney. And we're definitely not gonna wait. This is like a super serious thing. They're gonna need to be treated or they will die. Okay. So I think once we kind of got that muddy point out about like the definition of hyperacute, I think the question started to make more sense for people. So yeah. So it's within minutes to up to like a full day. And then your acute is like at least like a day after up to like maybe like a few weeks. All right. Ooh, let me just not spoil it. Okay, so number 6, a 35-year-old patient with advanced HIV, aka AIDS, they have a CD4 count of 90, presents with progressive dyspnea, non-productive cough, and a low-grade fever over the past 2 weeks. What condition could be occurring in this patient? And until we know for sure, is there anything that could be done for now? Okay, PJP, sure, yeah, for sure, right? Is there anything else that we can't necessarily rule out? Yeah, TB test. Yeah, potentially they could have TB. They could have like bacterial pneumonia. It could be other type. It could be yeah, it could be a bacterial. It could be other types of pneumonia. It could be tuberculosis. So let's say you take the TB test and it comes back zero in duration. What are we thinking about that? Does that rule it out 100%? No, because again, they have that weakened immune system. So if we don't know for sure if they may or may not have TB, you guys mentioned, yeah, you want to do a chest X-ray, you want to do sputum culture. That's great. All of these are great. O2 therapy, awesome. What do you guys think about implementing any sort of precautions? Like isolation precautions of any kind? Yeah, so which one? So you want which
Put them in their own room for
yeah,
now until we figure out what they have.
yeah, like is there so like what do you guys think about an airborne precautions?
Yeah.
So in this case, the PJP, which it's looking like more likely PJP, but your TB is airborne. Your PJP isn't airborne. It's like I think it's a droplet, but simply because it could be TB, we put them in airborne. Yeah, exactly. But put them in airborne precautions just because we can't rule it out. So like for example, when someone's has like pending MRSA swabs, we treat them as if they had MRSA and just have contact precautions up just in case. So do you guys like that idea? Like just in case they do have TB, we'll just put airborne precautions on?
Yeah.
Yeah. Cool. Until we can completely rule that out. Awesome. And you guys already mentioned a lot of really good things. Chest X-ray, sputum. Oh yeah. So a lot of really awesome things going on there. So then this is a continuation of your previous one. So same patient as number 6. So this guy's still here. Their chest X-ray reveals ground glass opacities, and the patient is getting this is Bactrim. They're getting TMP SMX. This is Bactrim. For suspected PJP, their status is worsening. They need more and more oxygen. Um, what is your best step in management? And this is kind of like again more like a finals type of question, but I just kind of felt like throwing it out where you're kind of mixing different concepts.
Yeah. Wouldn't you wanna intubate them? Because isn't this arts?
Yeah, it could be arts, right?
Although I don't see that option, so I don't know.
So other than so what is arts? What's the path of arts? What is the cause of arts?
It's inflammation that leads to atelectasis, that leads to fibrosis.
Okay. Do you think there's anything here that helps with
Oh,
that?
yeah, okay.
Yeah, exactly. So yeah. So yeah, that ground glass is so from what I looked up, so your ARDS is like a whiteout. Ground glass is kind of like that step in between, and PJP does usually present that way, but this could definitely lead to ARDS in the patient. It's very possible. And the corticosteroids they reduce inflammation, which is kind of that. So you saw how you kind of mixed the knowledge of your HIV and some of those opportunistic complications, and then kind of married it with the concept that you just tested on with the ARDS and vents. And then you used like your general knowledge of medications to answer the question. Yeah, you guys see how you did that?
Very cool.
Cool. And then here, so Bactrim, just for like a knowledge thing. Here, this one's B is saying discontinue Bactrim and apply broad spectrum. Doesn't really make sense. So this person has PJP. Bactrim is already like, it's not technically a narrow spectrum, but it's like the best antibiotic for PJP. So it wouldn't make sense to be like to take away the PJP specific antibiotic to put like a vancomycin, right? So that doesn't really make sense. Here it's just kind of like I'm just throwing out shit. uh cryptococcal, yeah, like whatever, bro. You got the main point was that you guys were able to recognize kind of again from the thing you just tested on. All right. And then last one is gonna be a Truvada based. He did tell you they'll test on Truvada. And also I would say keep in mind also like the generic name for this, especially for your NCLEX. So keep in mind that your NCLEX um they do not use brand names at all. It's all generic names. So yeah, make sure you know your generic names if possible, like if possible. Like even like one that I've never seen people actually use the generic name Kyaxylate. The NCLEX said sodium polystyrene or something like that. So just keep in mind your generics. And then also keep in mind, even for like this test, I think just consider the generics. So to note, tenofovir. But yeah, so this patient has HIV. They're given Truvada for the ART. They mentioned that they feel better. Can I stop taking it? What do you guys think is the best response? Yeah. So yeah, so the key things with Truvada is going to be do not abruptly stop it. One, it doesn't make sense to like you're not cured of your HIV. If you were to discontinue it, that HIV starts becoming more active. It could even become resistant to the medication, and now you're juggling more meds and whatnot. Additionally, like those symptoms can go away over time. That makes people not want to take them, for example. That's another important teaching. Let me see what else can be a good teaching for that. Let's see. For Truvada, because I know that's he literally told you no Truvada. So let me refresh. For prep also, yeah. Which I don't recall needing to know it, but yeah. Anything else? What does there's the iris, there's most of the things. It's best to be consistent with it. So take it same time, same day, with or without food, as long as it's consistent. That's your main thing. It can affect your kidneys and stuff. That's pretty much it. Yeah, that makes sense. Oh, one more thing actually I didn't really mention here. Kind of going back to that question number 3. We talked about PPI, we talked about H2 blockers. He mentioned specifically like you can have like topical antibiotics, right? Um, in general, when it comes to antibiotics, what do we assess before like giving an antibiotic or like to assess like if the patient can tolerate antibiotic in general? Like what does it affect? What organ does it affect? The kidney. So, oh, allergies too. Sure, yeah. And so what is going to be your good sort? Sure, yeah, the autotoxicity. So yeah, we can see.
Yeah.
Yeah, exactly. Your BUN over creatinine. But specifically like creatinine's gonna be the most creatinine, and like your creatinine clearance is like your most accurate. So these are the things that you want to assess, especially I think like specifically like he said, like gentamicin. Gentamicin specifically for sure is going to be affecting this kidney. So even though it's like a topical, it's still the same kind of idea. So autotoxicity, creatinine. All right. Sound good? We good on this?
Mm.
All right. And then give you guys all this, and then we will be good for this. And then next week is your DK, I believe.